So we are live.
We are live now, ma'am.
Okay. Good evening, everyone. A very warm welcome to the societies of Aurangabad, Akola, Akluj, Barmati, and Islampur. A very warm welcome to a series of e-classic for clinicians, PPH skill and drill. PPH, we all know, is a nightmare. How many practice sessions we do, what many webinars we do, we still are in a soup when we actually face PPH. Aurangabad, Akola, थोड़ा lag हो रहा है. वापस आ गया क्या? Shall I continue?
Yes, yeah, you can,
Okay.
yeah.
So after so many sessions of webinars of PPH, yesterday I finally faced again 2 more patients of PPH, and again I was in a soup. Though they were managed very well and they're doing well, but the hemoglobin of one patient dropped to 5 grams from 11 gram %. That was distressing for me. So this is the very purpose of this webinar, to make every clinician aware of all the guidelines, all the options available in management of PPH, be it the first response bundle, the use of oxytocics, carbetocin being a boon in this era, being all the procedures or how to the management of fluid and blood components in a patient of PPH, compression maneuvers, the devascularization sutures, use of NASG in the management of shock or internal iliac ligation. Then we have the Chhattisgarh balloon and SR cannula by Dr. Samartha. So these webinars make us aware of all the different available options. So before we discuss, let us all join our hands and pray to Ma Saraswati, the goddess of knowledge. May Ma Saraswati bless us all. That was very soothing. Now it is time to talk about the lady behind all this hard work, behind all these webinars. She has worked tirelessly day and night to spread knowledge in each and every society of Foxy, from north to south and east to west. Yes, we are talking about our most deserving Foxy presidential candidate 23, Dr. Sadhana Gupta. Madam is co-chair Suffolk NCT committee. She is Foxy representative to Suffolk 1821, Vice President Foxy 2016, and ICUG Governing Council member with Best Governing Council Award. Madam is corresponding national editor and peer reviewer of Journal of Obs and Gynae and Journal Suffolk. She is recipient of Korean Award thrice for Best Scientific Research Paper, 4 times Best AICOG Paper Award. Madam is author of so many books. She has organized so many CMEs, workshops, conferences, and she's recipient of so many awards. A very dynamic and hardworking person I know of, and I would appeal all of you to kindly vote for Madam. A very warm welcome to you, ma'am, and I request you to give your opinion and to invite and introduce our revered guest for today, Dr. Milind Shah, past Vice President Foxy, and Dr. Parag Vinaya.
Thank you, Babita. Thank you, Babita, and thank you for always being together. So once again, a warm welcome to our revered guest, Dr. Milind Shah, Dr. Parag Vinaya, all faculties and the office bearers of Aurangabad Akola, Akulj, Baramati and Islampur societies. My special thanks to Dr. Aparna Raul, Dr. Shraddha Pandikar from Aurangabad, Dr. Shyam Sundar S. Sri Ram, Dr. Prerna Jatkar from Akola, Dr. Priya Vishwakaram, Dr. Revati from Akluj, and Dr. Rajesh Kalkre and Dr. Ajit Balasaheb from Baramati, and Dr. Seema Praveen and Dr. Vishal from the Islampur, because only your effort and your coordination and your coming forward makes us that we are always together for all great learning and sharing from each other and sharing our experience. What about this e-classic for clinicians, which I coined around 1.5 years ago, because of the many inputs like the teachers like Dr. Jaishimari, what we have that they are really concerned that when they are having classes or discussion in conference, and they always put something that this is evidence which is sometimes inconsistent, which is conflicting, and all teachers very strongly feel the need that we must have a very, very strong foundation of basic and classical teaching, and only on that all the things the things add on so that we can do the best decision for our patients. So the series, the subject and the faculties what we choose, it is in the same aim that clinicians don't get confused with the so many conflicting the things, but they get clear message which is right from the very, very basic principle of the teaching of OB-GYN to the what the recent thing is going on in our field and how we can amalgamate in every setting. So this was the classic, like our classical music and dance, हम लोगों के साथ सुर रहते हैं, लेकिन हम उसमें पहले सारे राग सीखते हैं और उसके बाद हम लोग नए नए उसमें एक्सपेरिमेंट करते हैं. So this is for that, and I am really thankful for like having us so much of like togetherness and the loving association, and we meet such a great people, and it is a great pleasure to have a very, very close friends. We have traveled together in Foxy, in Isopar, in ICOG, in many, many associations since years. And we welcome warmly Dr. Milind Shah, and thank you, Dr. Milind, for like being with us as a reward guest for the today's webinar. And can I have Dr. Milind Shah's CV? So we know Dr. Milind Shah is very soft spoken, but his work is always very organized. He does so many things at ground root level. He has been the president ISOPRA from 2016 to 2018, president IMA, Solapur branch, founder, president of IHRF, honorary secretary general of the family planning, FAOPS, I think is a the association, I will say Milind will tell, Asia Oceanica Federation of Practical Perinatal Societies, and the vice president of Foxy in 2011. Second Vice President of ISPA, Deputy Secretary General INSAR, ex-chairman Rural Obstacle Committee of Foxy, Managing Committee member of IAG, peer reviewer of the JOGI, Steering Committee member of the Asia Safe Abortion Partnership, past President Solapur OBGYN Society, and he has been Professor and HOD in Department of OB-GYN, Gandhinath H Medical College, National Editor Member of Foxy website, and visited many, many countries. He is an ardent traveler, and a wonderful book he has authored on hypertensive disorder in pregnancy, pelvic organ prolapse, and it has come with the I think it is a second edition is there, and we have contributed to his book, and a active Rotarian. So Dr. Milind has been a very innovative, and in COVID times, how he, like he shared, we have so many programs that how he could serve the in COVID time and did not refuse any obstacle and give a very clear video messages that how everybody can actually serve the people, the patient with the COVID, and don't refuse it. And these is small thing, and like providing pulse oximeter at the rural PSCs. So Dr. Milind, it is the CV is very decorative, but his work is so ground level, and he's a person who is in the very, very advanced infertility and other practice, and a very busy person, but he always talks of the very, very important thing, which is important for our country, our people of our country, and average OB-GYN, which are spread across the country. A warm welcome, Milind. It is a great pleasure to have you, and we wish to listen to you. for your thoughts on this.
Thank you very much, Sadhna. It was indeed a great pleasure to, join this e-classic for clinicians. And I must congratulate you because, see, it's always and always a need to spread the knowledge. And I'm very sure this particular webinar or the class is going to give a lot of take-home messages because all said and done, PPH was always a threat for every practicing obstetricians. But the program which I was seeing, I was so actually happy to see that everything was covered so sequentially and that only academician and the persons who practice think of this synchrony of having the medical management, then the SR cannula, as well as the stepwise devascularization. We always and always said with availability of prostaglandins, newer actually molecules like carbetocin, the PPH has reduced. But no, with increasing trends of cesarean section, another actually the thing which is threatening obstetrician is the morbid placenta, which is leading to the PPH. And that's why nowadays, whenever I listen the stories from various corners of the country of PPH and related mortality or the morbidity, it is always and always related to the morbid adherent placenta. And that's why one need to think a lot as far as the PPH is concerned. Because the PPH without this particular actually the cause quite often gives a good success stories because of availability of all these various medicines. And we have learned a lot as well with the devascularization as well as the interventional radiologists, which is available at the even district level where we can think about the embolization. But still, when it comes to the placenta accreta syndrome spectrum, what we say, it's still a challenge which I see in many nursing homes. So I must, I think, say all the best for all these societies who have joined here to discuss on this. The Aurangabad, Akola, Akluz, Baramati, and Islampur had been to all these societies, Sadhna, so many times, like they're as good as my family members. And that's why when I saw the list, I said, oh, I'm again going back to home from my consulting room to meet you all. Parag is with me, and he also has faced actually this particular situation quite often in various clinics in Pune. We always used to discuss about this various difficulties in the obstetric practice. I'm very sure the conveners, Babita and Ayush, are going to do a great justice for this particular webinar. Rajendra Singh is very much here as a MOS president, who has also done a lot of innovative work in Maharashtra under aegis of MOS, and that is going to go a long way to help the women's actually the health. I can see the wonderful speakers, Sadhna yourself, because I heard you so many times. Always a good take-home message because I know your Jivan Jyoti hospital is so full and we discuss about it so many times. So those who does that practically again can speak in very, very confident way to tell their practical experiences. And Dr. Samarthi, yes, recently actually when we met, we discussed a lot about his cannula and we heard about that particular cannula. I have not used myself, but I'm very sure it is going to come in my room as well for the further use. Dr. Shashi is going to speak on the surgical part of it. And the last part is again very important about the difficult case situations, because all said and done, certain things come in front of you in very funny way. Recently, when we got one such case of placenta accreta, the bladder was totally adherent, and we were in dilemma how to actually manage because we wanted to save the patient. At the same time, we never wanted to leave her with the fistulae or the life, which is going to create a lot of issues for her further actually the life. And that's why we needed to have a lot of actually discussion among the urologists and ourselves to decide how we should plan this particular surgery. And that's why these difficult situations like this are going to well discuss with Dr. Dolly as well as Dr. Aditi. And there are so many experts actually the panelists I can see, Gorak, Supriya, Aparna. I'm not going to take the all names, but I'm very sure all that is going to help a lot. And to add on that, there are wonderful chairpersons as well. I can see Sneha, Sham, and Shraddha, Aparna. All of them, they're going to do a lot of things. And I can see on Jayasri and Vinod, who always keep on interacting about various cases from Akluz as well. And that's why I'm very sure this webinar is going to give a good take-home messages, lessons to not only clinicians, but also to the students, inspiring OBGYNs. They are going to help a lot way. I'm very sure, Sadhna, these efforts are going to help you a lot. You will definitely receive a lot of blessings from all those people as the Almighty. And we too wish you all the best for all your further ventures, because we need actually you for the various platforms, including Foxy. I wish you all the best. I wish all the participants. Probably I must have missed certain names, but please pardon me because we need to go to the academic session, which is more important and more actually the awaited sort of session. But I'm very sure this session is going to help us a lot. Thank you very much for this invitation. It's indeed pleasure to meet you all. Thank you.
Thank you, Dr. Milind, for your really like coming up so many important issue in your deep practice, and the placenta accreta spectrum is something which is actually emerging as a globally as a cause of maternal criticality and mortality. So thank you, Dr. Milind, and thank you for welcoming our all esteemed faculties, amongst President Dr. Rajesh Singh, all faculties. So that makes the really good start by the chief guest, and we wish that you will stay with us. So it is a great honor to have Dr. Parag Viniwale, who is the Vice Chair ICOG. Chitkala, can I have his CV? Very long association with Parag. It is around 25 years. He is known everywhere for his all like a very, very good teaching skill in every subject, whatever it is that he takes so well. He is a senior consultant OB-GYN from Pune, PG teacher and unit head, Kamala Nehru Hospital, President Pune Obs-GYN Society just last year. This year he has given charge, Vice Chairperson ICOG. He is currently and has been the Secretary of ICOG. President Menopause Society of Pune, Secretary ICOG, what I said, National Website Editor of Foxy, Peer Reviewer of Jongi, and he has been Chairman, Young Talent Promotion Committee, did a lot of work, and from that time, actually, the Young Talent Promotion Committee actually became a very desired committee, because actually it is the work which makes any association and any committee and anything very, very lucrative, because people see, oh, there are so many things. So that was due to Dr. Parag. He has been the co-editor of book My Gynecological Manual on Adolescent Girl and Young Women, Yearbook of OB-GYN 2019, which most of us have been gone through, exploring new horizon of OB-GYN. Ardent academic writer, delivered so many guest lecture, oration, and the recipient of Dr. C.S. Dawn Prize. Dr. Parag, it is so great to have you and your conferences, and we have been going so frequently to Pune, and it is we look forward to your address for this program.
Thank you, Dr. Sadhna. Good afternoon, all. I bring greetings from Pune, and it's indeed a pleasure to be sitting here with so many friends like Milind, Dr. Rajendra Singh, and everybody. First of all, thank you very much for the opportunity that you considered me worthy of being guest of honor, because there are so many academic activities going on, but I think the most sought after is PPH, because PPH is something which usually comes unnoticed. We are not prepared, and then suddenly it happens, and we really have to put our best foot forward to tackle it. Today's program looks very, very interesting. I'm sure it's going to be a great learning experience. So I look forward to learning a lot of things, especially the panel, because the case discussion teaches you small points which are really important when you are managing a patient. So once again, thank you very much for giving me this opportunity, and Sadhna, best wishes to you for your future endeavors. Thank you.
Thank you, Parag. And we really look forward to great work by you at the SUG and the future. So thank you very much. And we recognize the presence of teachers and teachers. Dr. Jayashree More, always Rajan Singh Pardesi is always there. And Dr. Gorakh has joined. And warm welcome, and all the faculties, Dr. Revti, Dr. Kavita, Dr. Sarupa, Dr. Aditi, who have joined as as faculty and with us from the very beginning. So, Babita, you can go
Yes.
ahead.
Thank you so much, ma'am. So without much ado, let's quickly move towards our scientific session. Our first talk is by Dr. Sadhana Gupta, ma'am. She's co-chair of Obesity Committee. I would like to invite our esteemed chairpersons for this session, Dr. Rajendra Singh Pardeshi. Sir has 28 paper presented, 21 in national and 7 in international conferences, 7 times Best Paper Award in Foxy's AICOG conferences. Sir was faculty in AICG 2011 and ECOG 2013 Bangkok. He was faculty in FIGO 2006 Kuala Lumpur and FIGO 2012 Rome. Sir was chairperson of Food and Drugs Committee Foxy in 2012 and 14 and was awarded Dr. Hansotia Best Committee Award Foxy. He was vice president Foxy in 2019-20 and was vice president AMOGS, and currently he is president AMOGS 22-24. A very warm welcome to you, sir. I would like to introduce Dr. Jayashree More. Ma'am has been awarded gold medal in Obs and Gynae by Marathwada University. She's in private practice for 31 years. She's working as a senior consultant at Medicover Hospital. She's attached to More Hospital at Aurangabad and More Hospital at Fulambri. He was workshop in charge at AICOG 2005, organizing secretary of AMOGS 2009. He's past president of Aurangabad Obs and Gynae Society, and the areas of interest being high-risk obstetrics, fetal monitoring, and sonography. A very warm welcome to you, ma'am. I would like to introduce Dr. Vinod Shethe. Sir is president of Akluj Obs and Gynae Society. He is practicing OBGYN at Shethe Maternity Home, Akluj, since 20 years. He's director and IVF consultant at Akluj IVF Center. His areas of interest being IVF, sonography, and high-risk obstetrics. A very warm welcome to you, sir. Now, I would like to hand over this virtual dice to our chairpersons to invite and introduce Dr. Sadhana Madam and to conduct the session.
Hello. Good afternoon, everybody. I think Sadhana Gupta ma'am doesn't need any introductions. But some point we have to add in her biodata. When I attended her conference in 2019 at Gorakhpur on saving mothers, it was a really excellent, and that was the sign she is a hardcore obstetrician. She is a hardcore obstetrician, and she has taken this initiative of PPH. Now all knows PPH now still a cause of 20 to 25% of maternal mortality. And she has taken this initiative to curb down this element. And we need leaders like Dr. Sadhana Gupta. She is the right person to address us on this PPH issue and today's talk on resuscitation and medical management of PPH. Madam, our sincere wishes to you for your future endeavor in Foxy as Foxy president. Thank you so much. And over to Dr. Sadhana Gupta, madam.
Thank you, Dr. Rajan, for your precious blessings and the wishes. And Chitkala, you stop the slide share, please. Yes. So with this, I'm going to be the what every obstetrician, when he or she is called, what he do. With this, I send my sincere regard to Dr. Jayashree More, because she was so busy in like getting her all preparation in abroad trip, but she is so kind enough that she is there, and it is really great to have the persons like Dr. Jayashree More and Dr. Rajendra Singh Pardeshi as the chair of the session. So with this, whenever you get called the PPH, or you are doing cesarean or conducting delivery, and when we think, anticipate, we feel in the gut that flow this patient is needing, what to do in the first hour that I will going to deal. So this was just glimpse of just AMOGS in the just last month, and it was great to have. And Dr. Rajendra Singh Pardeshi is I always see he's such a cool, he never like having any loud word, but his things goes so well and in an organized way. So Dr. Rajendra Singh Pardesi and with his all the team of AMOX and the Aurangabad, it is really wonderful to have the persons like him. So I've been reading from land of Buddha, who says we can never obtain peace in the outer world until we make peace with ourselves. So it is all about when we face PPH, it is the peace and the composure in our brain, hands, and the soul. That is the thing only we can then actually tackle this life-threatening situation in our practice. So we know the obstetrical hemorrhage is contributing a lot of maternal criticality and the mortality around 25 to 30%. And maybe in developing world, it is up to the 60% of the total maternal death. The conscious freaking thing is that the Africa and Asia constitute the major proportion of these maternal deaths. But actually, statistics is something which we look at very distant manner. As a obstetrician and gynecologist, right from our internship house job to become when we become senior, actually it is the thing which we are bound to get. What the nature have designed the human reproduction and the childbirth, that we are bound to get in 2 to 10% of all deliveries. Out of this, 1 by 1,000 can be life-threatening, really. And if we are not very aggressive in our management, it rapidly goes into the shock, then irreversible shock, organ failure, and death. The story does not end over there. It can cause a scar all over the life of the woman, severe anemia, secondary infertility, social issue. Patients are being abandoned due to hysterectomy. So it is something nobody can forget when a person actually faces PPH as a obstetrician, as a like a person or as a family. So it is in India when we are having the almost going to be the third largest economy, still the PPH is contributing to around 36% of maternal death. It actually, when we face PPH, actually it is something like a crisis. Whenever the like a life situation or what sends us some moment of crisis, it actually tests what are you investing in day to day in your hospital, in your system, and what is your personality, what is your leadership, what is your composure. It is often predicted, suddenly it presents like a thunderbolt, and we have a lot of causes for this, but important thing that it can be the fastest killer of any young age person. What we can have is sudden, it is something bold to everyone. In India, actually, what is the thing that as an Indian doctor, we have to be ready with everything. We are having poor population, very poor, middle, social, middle, high middle, upper limit, highest, and the maximum rich people, even that richness that we are not having in the developed world. So this is the complexity of our situation when we are having all age-old problem like anemia, delays, inadequate obstetrical care, issue of the good referral, but we have all the new things what Dr. Milind was addressing, that is the more cesarean, more placenta accreta spectrum, all medical comorbidities, which actually doesn't only make the patient high risk for PPH, but also we have to alter the management approach and patient on various drugs and the coagulopathies where there is a real gap in the knowledge. So prevention of life-threatening PPH, decision-making among boys on confusion, and making the managing PPH with success is the aim of all these webinars, because if we do suboptimal management of obstetrical hemorrhage, it threatens well-being of mother, neonate, family, and obstetrician, and all medical legal media and the social issue. What we have just 2 years ago, we lost one young doctor due to suicide because of so many social and the media pressure. So what is the way? It is alert readiness. So all the 3 delays, and we are really fortunate this at the current time, then our government is having very, very strong political will for the maternal and child health, and we have a good road 108. And when I was just in Jorhat 3 or 4 months ago, I was just visiting Brahmaputra Nadi bank, and I saw the water ambulance going from Modgil to Jorhat. And that is the way that as an obstetrician, we must come forward, that we reduce the mortality and morbidity related to PPH. Prevention is the thing. Prevention is the way of the modern and the future medicine. So the this prevention start not from the drug, not from the MTSL labor room, but it is start from our antenatal period, antenatal checkup, and we must be very, very careful in eliciting the history that this patient can be the high risk for PPH. And for this, we have to take the suggestive history. Many times patient doesn't tell that she had PPH, and suddenly when the labor room where the patient says, oh, last time also I had blood transfusion. So it is something which we have to inquire it always very, very careful location on the of the placenta, multi-fetal pregnancy we know, and the treatment with anticoagulant as well as the pre-existing bleeding disorder. What you do next? So as a expert clinician, you might be taking all history, but it gets lost because it is just on your mind. So this is very important that you identify all high risk factor 1, 2, 3, flash at antenatal card with the red pen, and sensitize all people in the family as well as labor room staff that whenever you read these, you have these 2 or 3 risk factor or 1 or 2, the all labor room staff is ready for all readiness to do the PPH. Now, active management of third stage of the labor is the thing which is a vaccine against the postpartum hemorrhage. And in my long 30 years journey in Foxy, I have been really fortunate. And when I look back in my the history in Foxy, I have a gratitude to Foxy that I was the part of many things what is happening in today, like keeping the oxytocin in the refrigerator. I was the first person for the path oxytocin initiative. Dr. Hema Devakar introduced me to Deepak to the path oxytocin. And at that time, before that, I was actually not aware that the oxytocin to be kept in the refrigerator like vaccine. And then path Karnataka studies and the UP studies and the all oxytocin is kept in the shelf. And when the patient needed, we needed oxytocin, it was not effective. So that gone on to a long series of the programs in the societies. And that was the thing that today almost 90 to 95% oxytocin is being kept in the fridge. So this is very, very important thing what our professional bodies can achieve when we are really coordinating and collaborating with the right kind of the people. So AMTSL or good thing, short in third stage, reduce severity of PPH, risk of PPH, reducing need of blood transfusion, anemia, other oxytocin, uterotonic medication. Initially, no advantage or disadvantage for baby, but now with the delayed cord clamping, it is the advantageous for the baby. And so what is the most important arm of AMTSL? That is the oxytocin administration, 10 unit either IM or IV within 1 minute of delivery of baby. And before what we said, that was a very strong study. What was the regular practice? And even our textbook sometimes say, give methyl ergometrin after delivery of placenta, which is actually the 4th stage. What is the beauty of oxytocin? That there is no contraindication. When we give intramuscular, there is a sustained uterine contraction, no effect on maternal pulse, BP, and vital. So even if the patient is not having IV access, 10 unit intramuscular is something which we can give in every woman irrespective of their, because there is absolutely no contraindication. Misoprostol as a management, as a drug for the active management of third stage of the labor is very frequently used by our obstetrician and gynae today. But I wish to emphasize that it is a second choice drug. Oxytocin is the first choice, and if it is available, it should be given. Important good point about misoprostol is that it is room stable, it is cheap, you can give it by various routes, but still it is a second choice. And in case of PPS, sometimes we have to be very careful about shivering, vomiting, diarrhea, and the pyrexia. So all professional bodies very strongly recommend that the oxytocin administration within 1 minute of the delivery of the baby is the most important. Now we have got the carbetocin. Now it is very known molecule. Important beauty of it is that it is long lasting oxytocin. So again, there is no contraindication and very, very strong affinity to the oxytocin receptor. After champion trial, for which India was the important part of it, Many studies have been done on cesarean, but now there is emerging role in the role that it is a very good drug for the active management of third stage of the labor after vaginal delivery as well. Important thing about carbetocin is it is not to be repeated like what all other drug we repeat, but not the carbetocin, because it is a very strong affinity for the oxytocin receptor, and it is never to be used before delivery of the infant. So this is important, and beauty of carbetocin is, especially in case of anemia, heart disease, preeclampsia, when we used to give the oxytocin for the 4 or 6 or 10 unit, 5 unit, actually the use of carbetocin eliminates the requirement for infusion after the initial days. So the fluid overload, where we don't desire the fluid overload in those situations, it is a very, very good drug. However, important thing is that all oxytocic agent must be available in a good storage position, and our nursing staff and all level of the junior doctors, MBBS doctors, primary health center doctors must know that this active management of third stage labor is going to happen. It is 100% women who get the institutional delivery must get it. So this is the important thing about message. And the next thing comes that it happens despite AMTSL, sometimes the people say, no, I use carbetocin, but we had PPH. So it is not that it prevents, but it can reduce the severity. So why do mothers die? Because we don't correct the hypovolemia and delay in control of bleeding. So this is very important, and it is a golden hour. It is the first hour where we should do the best, because whatever the cases are in the National Medical Council or in the legal court, everybody they don't accept that we delayed hysterectomy because the person was not giving consent, and we delayed the blood transfusion and it was not available, because everybody wants that we should give the aggressive and the optimum management in this first golden hour period. Primary PPH, secondary PPH, first 24 hours, then after 24 hours, we know. But when you get the call, what you do? First, you have to make the 360-degree review of whole situation and the cause analysis, which is going into the mind of obstetrician, because that leader is the thing that what as a OB-GYN, we might have anesthetists, we might have many people, but actually it is the cause analysis which is important. Very quick 360-degree view, what were the predisposing factor, when bleeding happened, it was difficult or not, and placenta was expelled fully or not, and that gives you idea that what can be the cause. It is torn tissue trauma or the thrombin patient, especially in the precedent situation like IUFD or the abruptio, when we think of the coagulopathy very, very early in our flow chart. So you have to have a very quick analysis as well as the review of record, whether the patient was having fibroid. Nowadays we are having a lot of issue that patient had fibroid and the PPH is happening and what to do. So this is important, that is a cause analysis, and always think that there can be more than two causes. It is not so that atony is there, trauma can be there, because many times difficult labor, use of oxytocin induction gives the patient all high risk factor for atonic as well as the traumatic postpartum hemorrhage. Now with this, how we have the pitfall in diagnosis is still today when we are having, because the nature have made the pregnant woman with the high blood volume. So she can actually tolerate the blood loss around 500, 400 ml without any change in the vital. And that's why we lose this opportunity of diagnosing in the first 2 hours or the first 30 minutes. So a very, very good, like with the HMS and so many PPH workshop, we have slightly improved that the visible estimation of the quantification of blood loss have improved. We have this Devdas bag. The Dr. Nalini Mishra has made very good Chhattisgarh, which we can make right at the point of care with the plastic apron, what we hang on the which is available in the safe delivery kit. So give clear instruction to labor room staff. If the patient have 5 soap normal size pad, or she has soap big sanitary napkin, or she is having continuous trickle of the blood. Most dangerous patient where we really miss the diagnosis, and altered woman condition, like patient is having nausea, air hunger, suddenly she vomits, suddenly she feel like having a confused, you are stitching episiotomy, no voice, nothing. So this is the time that you must be very sure that patient is not going into hypovolemic shock. Call for help, that is a blue code, that is important, and whom to call, it should be right cause analysis, like it should be in our mind. It is not the call to walls. We must have the pre-planned that whom to call when we have the PPH. Our friend anesthetist, senior and the smartest nurse, our one obstetrician colleague, smartest ward boy and the theater staff and the blood bank person. So this is very important because we know call to help, but that is more important, that whom we can trust in the terms of the crisis and who are competent enough and the confident enough to deal with the situation. After the diagnosis, the second thing is the quantification of PPH, because if there is more blood loss, you are going to have a more aggressive measure. So cause analysis and the moderate. So these are the Meo's chart. This is the how we can say pulse, blood pressure, tissue perfusion indicator, urine output, and the capillary refill. So it is not a rocket science, but it is a thing of the intuition and the grasping at the very quick level, very early level, that this patient might deteriorate because she is having a high pulse rate. And the shock index, which is a very, very simple measurement, that is heart rate divided by systolic blood pressure. But for this, it is a must that our labor room must have no compromise in that we have a multi-parameter cardiac monitor in our labor room. We owe this to our women. Our women have got this right to have the quality healthcare when they are giving birth. So it is a shock. If it is less than 1, you have a breathing space, but if it is more than 1, you have to be very aggressive, and the classical rule of the 30. What we must have, you have diagnosed PPH, you have quantified it, but what next you have? Everything is ready 24/7. You have to see all the drug, oxygen cylinder, key for oxygen cylinder, emergency tray for PPH charts, and all contact number. So this is the thing what we have to say. What we say, you sweat more in peace, you bled less in the war. So this is the basic EMOC. You have to give the like a 2 IV cannula. This is very, very important that we must have either gray or the green cannula, no role of the pink cannula in our labor room. And if the patient is having institutional delivery, it is better always, and I will say it is must that every woman have the IV access. You have to record event, and when there is a blood loss of around 500 to 1000 ml, it is a full protocol for the resuscitation. So check for airway, breathing, circulation. Whatever is the oxygen saturation, you give oxygen by mask, and the green and the gray cannula, and always the 2 cannula, because we never know that women with PPH will go this in what way in the next half an hour. Keep the position of the woman flat, very important. Keep the woman warm. Sometimes the AC is on the very low temperature, and this is important. We are very careful for all reason about the temperature of our labor room. And until blood is available, this is the very, very important step. Infuse up to the 3 times what we have estimated the blood loss, and that is the crystalloid warm fluid very, very rapidly. Catheterize the blood and assess what is the need of blood transfusion with the quick hemoglobin test and the indices of shock and ongoing bleeding. Manual aortic compression, like think that you are standing on the stool, putting your straight hand straight, and the thumb is outside, and giving that much of pressure on aorta after shifting the uterus that you don't feel the femoral. These situations when there is a sudden catastrophic PPH, and especially in the situation like placenta accreta spectrum. So this is the resuscitation, and when you are giving this crystalloid rapidly, at the same time when you are giving first or the second IV line, it is must that you send the blood at the same time for the cross matching, for the all basic hemogram, liver function, kidney function test, and the coagulation profile, because many times the patient is having cold because of the hypovolemia, and it is not easy to have access to the IV line. So this is the time that you send the test. So it is PPH care bundle as a Foxy presidential candidate. It is one of my statement, one of my vision, that we will like aware every OB-GYN across the country about all maternal bundle care and reduce the maternal and neonatal criticality and the morbidity. So the first line response are the isotonic crystalloid uterotonic drug, tranexamic acid and uterine massage. And second, when it is refractory, we are going to have in the second session. So it is all what I have said: warm, flat, cause analysis, catheterization, and important thing, it is crystalloid, means it is either ringer lactate or normal saline. It is not hemaxil. Many times still the anesthetic or somebody start with the hemaxil. It is not, it is costly. Colloids remain intravascular for a long time, more chances of pulmonary edema, and it interferes with the coagulation test. So it is ringer lactate and normal saline, 3 times what you are estimating the blood loss, and it should be rapid. Ask always right question, what we say 360-degree review, placenta delivered. If not, it was complete. Bleeding start after delivery, before delivery. Placenta not delivered, immediate mobilize team for MRP, not complete, explore genital tract in good setting. But if there is a suspicion of past disorder like the previous history of DNC or a little bit doubt on ultrasound, never go for the MRP, because that can cause the life-threatening hemorrhage. Catheterization, very important. You see what is the kidney perfusion with the amount of urine. It is hematuria that may cause some injury about it, or the very prolonged labor. Fundal massage, it is again a art. It is not a something rubbing. It is a circular, gentle movement and not a vigorous rubbing. And always remove the blood clot from the vagina, because it induces the uterus contractibility as well, and identify fundus of uterus very carefully in obese women. Now coming to the medical drugs. So oxytocin, carbetocin, methyl, all these drugs are with us. We are very fortunate to have a good number of drugs which are affecting on different receptors. 2 important things: they must be stored well, they must be available, exclusion of contraindication of every drug, and optimize the number of doses. So if it is methyl ergometrin, you can give around 4 to 5 days. PGF2 alpha around 2 milligram, that is 0.25, almost 8 dose. Misoprostol 600 to 800 milligram. So important thing is that we might be knowing many things, but it should be available to us at that time, and optimize that you give the optimum dose. Don't take the patient for the laparotomy or the second line measure unless you have given the optimum dose of every drug. Different drug act on the different receptors, so it is very reasonable that if the PGF2 alpha is not working, methyl ergometrin will work. And still we will say, because of the constant, the overall uterine contraction, methyl ergometrin really works in certain situations so very well. So it is a first, second and third line, and you can, PPH is the thing where we have to be very aggressive and proactive in the use of drug. So this is all that what we must know: the contraindication, anemia, heart disease, no methyl ergometrin, this thing, the asthma, then no prostaglandin. And yet if after 3 doses of any drug the patient is not responding, she is having bleeding, this is the time that we go for the laparotomy and the second line measure. Tranexamic acid have come in a big way after the women trial. And what I say, we look back that the first women trial in the FIGO, Vancouver, we have this study of the paper. We have a lot of questions from the many countries, and the Pakistan, many countries represented. And now it is a recommendation that tranexamic acid should be given within 1 hour of the PPH, or even prophylactic in the high risk cases. So tranexamic acid is a strong recommendation for the management of PPH, but it is not to be given after 3 hours. After that, it can cause the harm as well. So it is to be given, if it is to be given within the 1 and the 2 hours. Another very important thing is that we have found this very important paper from the Anesthetic Association, that is from 2020, who says that there have been report of the inadvertent administration of tranexamic acid for the use of the regional anesthesia, because ampule is same and the anesthetist take it as a bupivacaine. In National Medical Council, when few people are member, they also say that we have this like mortality after the inadvertent injection of tranexamic acid as regional anesthesia. So it is a non-technical point, but important that the magnifying glass should also be there in the operation theater, because all have written so small and sometimes many injections are same and we are having human error. So this is something what I want to know. When to consider blood transfusion, have a quick check HemoQ. If it is around 7, this is time to look for the consideration that patient need the blood component, and look for what is happening, what is the patient is ongoing bleeding, or what has been the antecedent for the coagulopathy like abruptio, preeclampsia, HELP, or DIC. So any diagnosis for the DIC, the first thing is that there must be precedent obstetrical situation for this. And if you think that it is coagulopathy, go for all coagulation profile, but never forget you can do very, very easily these simple point of care tests. A wonderful paper by Dr. Nalini Mishra, which has been presented, which has been published in the FIGO House International Journal of the OB-GYN, that how this bleeding time, clotting time correlates so very well with the fibrinogen level. Massive transfusion protocol, that is 1:1:1, but I just wish to say that it start after 3 or 4 unit of PRBC, not from the very beginning. It is 1:1:1 unless there has been the something like a coagulopathy or the thrombocytopenia issue. We want to achieve certain parameter, hemoglobin more than 8, platelet count 75, prothrombin time. So we have to have certain indication. Always be ready with all tray and the trolleys, and record and communication is very, very important. By Manyata, we have been reaching to the paramedics of very, very remote areas, and they become confident in this first hour management and the recognizing PPH. Bimanual uterine compression, it is the art which we have to be retained, SR is going to have. And important thing is again a decision when to shift into for the operation theater. Good exposure to be done in OT, and a great contribution by Dr. Pally for the transvaginal uterine artery clamp and our own Chhattisgarh balloon. And just like 7 days ago, I actually bought one Bakri balloon just by the way, and patient after cesarean, she has a lot of things, tuberculosis, thyroid, so many things. She had anemia, and that like balloon gives us such a beautiful immediate like stopping of bleeding, and you don't know that which day which thing is going to work. And we have to be ready with all Foley's catheter, uterine, the condom, all thread, and all the basic skill. And I can say that who are in the institution, the purchasing of one Bakri balloon is not that bad, because I thought because it was there, because you don't have to waste even 3 or 4 minutes to making it, and it is very, very easy. And the fatality, always beware when there is a retained placenta, mobilize earliest for the MRP. I really have a sudden collapse within 5 or 10 minutes of retained placenta. What I do not says that the real difficult part about MRP is decision to undertake it. So don't delay it. More the time between retained placenta and removal, more chances of having the more PPH. Always look for the coagulopathy. We have the medical disorder like a drug-induced thrombocytopenia, APLA, SLE, viral infection, and you have to be very confident that this is time to open. And what are the decision points? Uterus totally flabby, lacks pouring blood, unstable vital, unstable hemodynamic status. You are not able to such a high cervical tear, and patient is getting down. Indefinite contour of uterus, you are suspecting some injury or the hematoma or the rupture. Lump fell per abdominally, this is the time to look into it. Go stepwise what you have to do. So finally, we have to save lives everywhere. Every woman, wherever she resides, she must have a good, the safe delivery. She has this right. And as a obstetrician, it is our prime duty to give these services. It is a drastic situation needing aggressive management, good protocol, good decision, make a team readiness and the friend readiness. And when the surgery at the second or the third level required, never delayed. So if you can fill the unforgiving minute with the 60-second worth of distance, run. So it is most due for the postpartum hemorrhage. With this, I seek everybody's support, blessings, and the wishes for my Foxy presidential election. Voting will be from 1st August to 10th August. And I'm ready with the vision. I have many things with the leaders like you, but like all leaders, we want to work together so that we are proud of making our country healthy, and we are proud of having a very strong fellowship among our OB-GYN across the country. So thank you very much once again for this opportunity and coming together for our all initiatives.
Hello. Thank you, madam. Thank you for your the nightmare. What we are thinking. The nightmare, the PPH. What we are thinking. We are very much worried about the PPH. I am in rural area actually. It's very difficult to manage the PPH cases. Thank you for your discussion on the methargine, pitocin, misoprostol. A few days back also we are having the same topic. At that time, they have suggested keep the ready the peoples who can help in such situation, and you also talk on the same thing. We should assume which patient will go in the PPH. We should have the blood bank ready. We should have the platelets and fiber, all factors. So thank you for your the brief discussion, importance, and the nightmare topic, which will give the guidance to the peoples like us who are practicing in the rural area. Thank you, madam. Thank you very much.
Thank you, Sadhana Gupta, madam. It was an excellent talk. My only one question is, madam, we have shifted to giving injection carbetocin during seizure as the first line nowadays. But we are still not giving it in a vaginal delivery, because whenever I gave it, maybe a few times, there was an increased incidence of retained placenta. It came out later on. So still, what do you suggest? Whether it should be first line in vaginal delivery or not?
Madam, it is a first, actually what is our experience till now, that it is a first studies were that it is non-inferior to oxytocin. Now we have the studies in the carbetocin can be superior to oxytocin.
Yeah,
the important thing is that the most of the studies has been done initially on the carbetocin, because we can all have the time of delivery and the postpartum hemorrhage. So, but the all professional body says that it is a very, very good drug, especially in our setting when we have 39-40 degree temperature. And the vaginal delivery, the only constraint is the cost. It is not efficacy. So somehow, yes, your experience may be patient related, but I am using in all cesarean and vaginal delivery. Actually, I have totally switched to the carbetocin, and placenta actually removes the expelled just very minute. Just the first minute, and it is not, the mode of action is the same, because it is the same. Elective cesarean section, the carbetocin act as a upper level, because there is no endogenous oxytocin in elective cesarean section. So carbetocin is a much better drug in the elective cesarean, and in the routine thing, and only the public health sector cost and availability is issue. And when the pharma people will give the carbetocin at a low cost in the public health, I think that will be our preferred drug.
Yeah. So at present in Aurangabad, mostly we are using it for seizures, elective caesareans, but still sticking to the age-old oxytocin for the vaginal delivery. Yeah. Thank you, ma'am. Thank you to all the conveners also for giving me a chance. Thank you very much.
Dr. Rajan,
Sir, we would like your input also, Dr. Rajendra sir.
Rajendra Singh Pardeshi.
Dr.
Ayub.
Rajendra sir is there. Sir, kindly unmute yourself.
Thank you, Dr. Sadhana Gupta. It was really an excellent talk as usual, and you had given many insights to all the delegates and participants. And as Dr. Vinod told, it's a really nightmare still, and in rural areas, really difficult to practice because many facilities they are not available. Even blood facility also in taluka level. Now the storage facility, government is now implementing the storage facilities and all that. But this topic really, your talk will really help all the participants. Thank you so much.
Dr. Vinod, I will say something to the, like in a practicing rural and sometimes you are all alone. So you say that how to call 2 or 3 things what we can have, that availability of PPH box, availability of all the drugs, and that SR cannula Samartha is going to have as a transvaginal uterine tube. Because if you refer, if we really don't have the blood and we don't have that team, then we can refer at the right time when the patient is not having irreversible shock. So the good resuscitation and the what you say, what will pay you, that is the PPH drugs, pay PPH instrument, pay, and you're like a methodical analysis. And SR cannula, when you will listen to him, that it is almost 99 to 100% effective. So it is, you can do, and then the timely referral with all the precautions. So that is my way to address your question.
Thank you, madam. Thank you.
So that was a very, very interesting session. And as usual, ma'am has covered almost every aspect of PPH. So let's move forward to a very interesting session. It is a video demonstration of SR cannula by Dr. Samarth Ram. For this, I would like to invite our esteemed chairpersons, Dr. Aparna Raul. Madam is core fertility specialist at Aurangabad International IVF Center. She is practicing since 25 years and has received the Young Scientist Award at AICUG Hyderabad and Siliguri. She has received Young Gynecologist Award at Asia Oceania Congress at Malaysia in 1998. She is faculty and at various national and international conferences. A very warm welcome to you, ma'am. I would like to invite Dr. Shraddha Parikar. Madam is ENB of OBGYN, Nanavati Hospital, Mumbai. She is Honorary Secretary, Aurangabad for the year 23-24. Past Clinical Secretary of Aurangabad and past Cultural Secretary of Aurangabad Obs and Gynae Society. A very warm welcome to you, ma'am. And I would hand over the session to the chairpersons, and I request Dr. Shraddha to introduce Dr. Samarth Ram.
Thank you, ma'am. I'm really privileged to introduce Dr. Samarth Ram. Sir is a recipient of many awards, like he's winner of prestigious senior category Foxy Korean Award, a 3 times winner of Dr. C.S. Dawn Prize, Foxy Figo Award, KFOG President Gold Medalist and Yuva Foxy Award. And his PPH suction cannula and oral hydration therapy to prevent severe PE could bring down the maternal mortality rate very significantly in Kerala, Tamil Nadu, and Andhra Pradesh. Sir has various publications to his credit. More than 26 original papers he has submitted in national and international journals. His areas of special interest are postpartum hemorrhage, preeclampsia, and amniotic fluid optical density guided induction of labor. Welcome, sir.
Hello. Am I audible to you?
Yes, sir.
And you share the screen. Yes. I think I'm audible to you now. Hello. Hello.
Yes, sir.
You're audible.
Very
Yes,
good.
really
Thank
audible.
you. Good evening, chairpersons, and good evening, everybody. Very much thankful for the Sadhana Gupta ji for giving me this opportunity. I am there with her during her entire program, and I wish her best of luck in forthcoming presidential election. The SRPP suction cannula is known in the entire South India now, which is responsible for bringing down the maternal mortality to a very significantly low level. I'm expecting by the year end of this year or another 8 months, 12 months, MMR in South India is going to touch less than 30. That's what we are expecting. MMR in Kerala has come down to 19 now, which was never before. The title of the topic I'm presenting, SRPP suction cannula for the management of atonic postpartum hemorrhage. Greetings from God's own country, Kerala. Postpartum hemorrhage is the leading cause of maternal deaths all over the world, amounting to 28%. Around 50% of the mothers die due to atonic PPH. And conservative methods like uterine massage, uterotonic drugs, and balloon tamponade fail. Surgical interventions which need laparotomy are needed to stop bleeding. In low resource settings, it is difficult to organize competent manpower, compatible blood, and transport to higher medical centers. Many times, mothers die on roads while being transported to higher medical centers. This is SRPP suction cannula that I have developed, measures 23 centimeters long. And this is a fundal portion having larger holes, and cervical portion is having smaller holes. This is the vaginal portion not having any holes. Nipple of the cannula will stay outside to be connected to suction machine through tubing. Then coming to the mechanism, how it works. This is atonic flabby uterus bleeding, cannula inserted here. And when negative pressure applied, the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent. Uterus becomes a closed cavity. Further continuation of a negative pressure results in constriction, contraction, and firm retraction of uterus on the surface of the cannula, which assists the natural physiological process of contraction and retraction to stop atonic bleeding. Here, I am showing the uterus here. Inside this uterus, there's a cannula working and creating a powerful negative pressure. And it is a global constriction of the uterus. That it does mean it affects all the vessels. And you can see, because of the global constriction of the uterus, you can see a coarse ridges on the entire surface of the uterus, that is both on upper and lower segments. For the same reason, cannula is very effective to stop bleeding even from lower uterine segment. I would like to repeat once again, SR cannula is very effective to stop lower uterine segment bleeding in case of placenta previa. Achieving closed uterine cavity is a basic and fundamental requirement for the functioning of suction tamponade system. 5 different sizes of cannulas are made to match different cervical dilatations and to match different uterocervical lengths. Different obstetric bleeding situations have different cervical dilatations and different uterocervical lengths. For the same reason, it is not possible to achieve closed uterine cavity with a single design of cannula. There is a post-abortal uterus where the uterocervical length is short and the cervix admits only one finger. You have to use a thin cannula. And this is the postpartum uterus where the dilatation of 8 to 10 centimeters and the uterocervical canal length is longer, and you have to use a larger diameter cannula. If you use a thin cannula in immediate postpartum uterus, this thin cannula stays at some corner of the cervical region, and the cervix cannot grip the cannula well, and for the same reason it cannot produce an effective closed uterine cavity. For the same reason it do not work well. These are the cannulas designed for atonic PPH after vaginal delivery, lateral view and anterior posterior view. Thin cannula meant for admitting one finger, the larger diameter cannula for dilated cervix. These are the cannulas designed for atonic PPH during cesarean section. Thin cannula meant for cervix admitting one finger, and this larger diameter cannula meant for a dilated cervix. Also, I have given a marking here on the cannula so that to differentiate cervical portion and fundal portion. The basic requirement here, we have to keep the cervical portion, the cervical region of the uterus to make the cannula system works well. And this is the cannula designed for bleeding after MTP or vesicular molar extraction. This is a thin long cannula. There's an angle here. Also, we use this cannula as a suction tube introducer while doing a cesarean section. When compared to balloon tamponade, in balloon tamponade, the mechanism is totally opposite. Here, the water-filled balloon dilates uterine cavity and a distended balloon compresses the bleeding sinusoid to stop bleeding. Whereas the vacuum tamponade system assists the natural physiological process of contraction and retraction to stop atonic bleeding. SR cannula application for atonic PPH during vaginal delivery. I would like to show a small video here.
Woman bleeding profusely. Vagina retracted with white blood speck like this. 5 centimeters of anterior cervix is caught with the sponge holding forceps like this. Cannula inserted. Tip of the cannula should be at the level of fundus and should be felt bimanually. Nipple of the cannula should be connected to the suction machine through tubing. Negative pressure should be applied. A negative pressure of 650 millimeters mercury should be applied for 10 to 15 minutes. We can see complete cessation of bleeding within 4 minutes. Retracted well.
Application of negative pressure. A negative pressure of 650 millimeters mercury should be created and maintained for 10 to 15 minutes, and then the machine should be put off. This procedure should be repeated every hour for 2 to 3 hours. After 3 hours, the cannula should be kept in the same position without removal and should watch for bleeding. In case of recurrence of bleeding, negative pressure should be applied by just switching on the machine. Then the question is how long to keep the cannula inside the uterus. Usually, the cannula can be removed after 6 to 8 hours. In case of high-risk women, cannula can be kept inside the uterus as long as the bleeding expected, even after 24 hours. Whenever there's a recurrence of bleeding, just we can put on the suction machine and the bleeding stops instantaneously. SR cannula application for atonic PPH during cesarean section.
Cannula system should be organized while setting the trolley itself. The intended cannula for application should be fixed to one side of the suction tube. Other end of the suction tube should be fixed with a thin long cannula. As this is an elective section, I am dilating this cervix with index finger. I use thin long cannula, which I call it as a number 5 cannula, as a suction tube introducer. Suction tube should be connected to the suction machine. Cannula should be kept in proper position like this. Cut edges should be kept close together. Mop pressure applied. Negative pressure applied. You can see complete cessation of bleeding, contracted and well retracted uterus. You can see practically no bleeding. I am closing the left angle under direct vision. Contracted and retracted uterus. Blood loss less than 100 ml.
Police catheter, tourniquet, and SR cannula for lower segment bleeding in case of placenta previa. In case of placenta previa, this technique is very useful in peripheral centers with suboptimal facilities. After placental delivery, after exteriorizing the uterus, you can apply Foley's catheter as a tourniquet on the lower segment, which instantaneously stops bleeding. Very useful in case of placenta previa. Now the bleeding completely stopped now.
As Foley's catheter is elastic, It permits the application of SR cannula with in situ tourniquet. Put on the machine.
After application of negative pressure, you can see firm contraction and retraction of uterus. You can remove the Foley's catheter and you can suture the wound.
You can see complete cessation of bleeding with contracted and retracted uterus.
One important information I would like to share with you here is to apply negative pressure, you need not close the uterus with sutures. You can just keep the cut edges close together and apply negative pressure. Just because of a valvular mechanism, the wound itself get come close together and a closed uterine cavity will be achieved, and uterus start contracting and retracting, and bleeding instantaneously stops, and you can start suturing. Prophylactic application of SR cannula is done for women who are at high risk for developing atonic PPH like PIH, anemia complicating pregnancy, and accidental hemorrhage, and so on.
For prophylactic application, we have to check the suction machine before the delivery itself for proper functioning. And we have to organize the cannula system. Cannula should be firmly fixed to the one end of the suction tube. Other end of the suction tube should be firmly fixed to the suction machine like this. After the delivery of the baby and before the delivery of the placenta, vagina retracted with white blood speculum. Mild traction on the umbilical cord. 5 centimeters of anterior cervix caught with the sponge holding forceps like this. After the delivery of the placenta, without wasting any time, left 2 fingers inserted deep into the cervix, cannula inserted into the uterine cavity, taking the guidance of left fingers, tip of the cannula at the level of fundus, negative pressure applied. You can see complete cessation of bleeding. Total blood loss is around 50 ml.
One important
Retracted well.
One important information I would like to share here is immediately after placental delivery, the cervix will close so quickly. So in case of prophylactic application, you have to keep everything ready and you have to insert a cannula within 10 to 15 minutes, 15 seconds time. Then it will be very effective and prevent blood loss. SR cannula for traumatic PPH. I suggest to apply SR cannula for every case of PPH, whether it is traumatic or atonic. In case of advanced traumatic PPH, some amount of uterine atony is always possible. Cannula corrects this atonic component and reduces bleeding. When negative pressure applied, cervical tissues get compressed firmly on cannula and stops blood flow in descending cervical vessels. If we apply gentle traction on the suction tube and cannula, the entire uterus en masse descends down. We can apply speculum, visualize the tears better, and you can suture the tears, cervical or vaginal tears easily, because no blood is coming from the uterine fundus and the field is bloodless. Here, we don't need to apply sponge holders to catch hold of the cervix. SR cannula for transporting the woman with PPH. This is the manual suction pump which we use for transporting the woman for higher medical centers. It's equally effective and it doesn't need power, and this can be used during transport in an ambulance and also in peripheral centers where there's no PHC, CSC, where there's no power supply. Also, this is very useful.
Manual suction pump can also be used to create negative pressure inside uterine cavity. This is useful in places where there is no power and also helps to transport the patient with in situ cannula.
Then the question is how to remove SR cannula after the procedure. After the completion of the procedure, the cannula cannot be removed easily as the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent. Cannula can be removed easily.
Cannula can be easily removed after gentle separation of these adhesions with finger manipulation like this.
This is the cesarean section I did last night. Next morning I'm removing.
You will see now.
We have to insert the index finger between cervix and the cannula and sweep around the cannula and separate the stuck tissues into the holes of the cannula, cervical tissues. Once you detach the cervical tissues in the holes from the holes, the cannula come out easily like this. Then somebody was asking how to clean the cannulas, or there's some problem, and I have made a small video for them.
To clean the cannula, immerse the cannula inside water. Kink the suction tube and put on suction machine and create high negative pressure inside the suction bottle. Then release the kink. By gush of entry of water inside the cannula get cleaned.
Then the question is, somebody was asking whether SR cannula can produce inversion of uterus. SR cannula do not produce inversion of uterus, but inversion of uterus can be treated with the SR cannula. Just you have to reposition the uterus back into the abdomen. You have to insert the cannula into the cervical canal as usual, and we apply negative pressure. The atony in the uterus disappears and it prevents recurrence of inversion. Cannula is also very effective to stop uterine bleeding, even in case of coagulation failure. And this is a case of quivillary uterus with coagulation dysfunction. Cannula is inserted here. You could save the mother and her fertility function. In fact, SR cannula was used extensively in case of COVID-19 infection in many medical colleges. With cases with coagulation dysfunction also could be saved with the SR cannula. I have given my number on the cannula itself, and people can call me whenever there's an emergency. I definitely attend to them. I would like to share some information how rapidly the SR cannula is spreading in South India. Under care of government of Andhra Pradesh, SR cannula and oral hydration therapy to prevent severe preeclampsia and eclampsia were introduced in Chittoor district of Andhra Pradesh in July 2018. Hands-on training workshop was conducted at District Hospital Chittoor. Suction cannulas were provided to all institutions conducting deliveries like PHC, CHC, area hospitals, and all medical colleges. ANMs and ASHA workers were assigned the job of OHT to all antenatal mothers to prevent preeclampsia. Oral hydration therapy is nothing but making every antenatal mother to consume more than 3 liters of water after 24 weeks of gestation to prevent severe preeclampsia and eclampsia. In peripheral centers with suboptimal facilities, we advise a prophylactic application of SR cannula to all women, both in case of vaginal deliveries and cesarean sections. Here, I would like to give the results of after three months review I have given here. You can see here 8,396 deliveries occurred. 1,500 applications have taken place within 3 months' time in the entire districts. SR cannula application, 1,074 applications for vaginal deliveries and 429 applications for cesarean sections. You can see there's no maternal death occurred during this 3 months' time after application of SR cannula. If you observe the blood transfusions here, only 28 units of blood was given for bleeding for 8,396 deliveries. And you can see the comments of the doctors on SR cannula performance. You can see CO2 P2 in a minimal blood loss, PPH control is good, applied prophylactically, minimal blood. So nobody made any adverse comments on this. This performance is excellent. And this is the 5 years performance of SR cannula and OHT. OHT in Chittoor district. You can see here SR cannula and OHT was started in 2018 here. Before that, if you see 47 maternal deaths were there between 2017 17, 18. Now 22, 23, 41 deaths have come down to 9 deaths. And MMR is 88, 96, 79, 83. It has come down to 33.3. It is such a drastic reduction is there. And one most important thing I would like to share here, I would like you to understand is the 16 maternal deaths due to pregnancy and hypertension has come down to 1 death last year. So this is the I would like to say OHT is very effective to prevent maternal deaths due to pregnancy and hypertension. There is a this significant reduction in MMR is due to the combined effect of SR cannula and OHT. Now, entire Tamil Nadu, Kerala, over 80% of Andhra Pradesh and many major hospitals in Karnataka are using this SR cannula to prevent and treat PPH. Kerala Federation of Obstetrics and Gynecology had included this device in obstetric protocols to prevent and treat PPH. This is the MMR of South India, very recent bulletin by the government of India. You can see the drastic reduction in maternal deaths in the entire 4 South Indian states. The Kerala MMR dropped to 19, which was never before. SRPPH suction cannula is a breakthrough innovation to prevent and treat atonic PPH. There's a paradigm shift in the management of PPH now. The panic adrenaline rush of the obstetrician had gone now. The simple, cost-effective, life-saving and fertility-saving technique, this is a physical method, does not depend on biological factors for its action. For the same reason, it does not fail. There's no need to maintain cold chain when compared to drugs. Suction cannula system can be organized within 2 minutes time. Bleeding stops just within 2 to 3 minutes. Cannula system works well even in case of coagulation failure. Even staff nurses can be trained and the bleeding can be stopped without any delay. Highly cost-effective, autoclavable and reusable instrument. Helps to reduce maternal mortality due to atonic PPH in low resource settings. SR cannula should be made available at every delivery point in the country, and it should be used as a first defense, not as a last desperate resort after failure of all other methods. No child should become motherless in this country. We should achieve PPH death-free India and PPH death-free universe. Thank you. Jai Hind.
That was a very nice lecture by sir. I think I've seen. Hello.
Please, ma. I'm able to.
I think I've seen your demo in AICOG Bangalore or somewhere.
Every conference there is SR cannula. I'm always there.
You were there by the inventor himself. I admit you, and it was a very nice initiative which you have done, reduce maternal mortality.
Yes,
we hope this cannulas use like it grows in central and North India also, like everywhere they are using in South India.
Yes, I'm trying my level best to introduce this in North India. I'm expecting a lot of things from Sadhana Gupta when she become a president.
Sure, sir.
So that's the thing.
Now we can go for the panel discussion, I think.
Sir, can I ask a query? I'm Dr. Swarupa here from Thane. Madam, am I allowed?
Yeah. Oh, you can ask me any number of questions.
Sir, I just had a question. Since this particular cannula has got multiple perforations, like if somebody has it right at the emergency time, it is great. But suppose somebody doesn't have, then our normal suction cannula may be a little larger bore, which we use for MTP, say 10 number or 12 number. Either that or routine abdominal cavity suction can be used as just to tide over the crisis.
But one thing I would like to ask you, the basic requirement of the cannula system to work is we have to achieve a closed uterine cavity. You should have holes in the cervical region. You should have holes in the fundal region. Then only it works. If you have only tip at the, only if you have a hole in the tip, no, it will work as, it works only as a suction tip. It will go on sucking the blood as a blood collecting from the walls of the uterus, and you'll be going on sucking the blood from the uterine cavity.
No, sir. Why I ask this question is when we routinely do MTP and when we finish MTP, we actually can feel that uterine cavity contracting on the cannula.
Agree, it is only temporarily, but it's not sustainable. Hello.
Okay.
It is
Okay, sir.
not sustainable. In fact, last time we had an emergency call from Haryana. She was not having cannula with her and she was profusely bleeding and she was not able to open the abdomen and do something. That time she called me. What I did, no, I asked her to show me one suction tube, disposable suction tube. I made her improvise put holes on the cannula and on the suction tube itself. I improvised a cannula for her there only, and we applied that suction tube itself as a cannula. We could save the mother.
Okay, sir. That is very nice.
I think it is the holes that create negative pressure all around. With one single hole, you can't achieve that.
No, actually, the cervical holes will immediately get closed once the uterus gets sucked into the holes. The real holes which are patent are at the level of fundus. So those are the holes which may go on sucking continuously and make the uterus maintain contraction and retraction. This is a system. You cannot.
Got it. I got it, sir. Got it.
Yes.
Sir,
Thank you. Thank
sir,
you so
will
much.
it not like we will be sucking the blood and will it not be like there is more of blood loss and we don't know that we are losing blood?
No, really what happens, it makes uterus contract and retract. It is
in how much time?
Within 2 minutes time.
Within 2 minutes.
See, what I tell you, the cessation of bleeding is not because of sucking. It makes the uterus contract and retract so firmly, it assists the natural physiological process of contraction and retraction. The normal ligatures are strengthened, and that's the reason why it stops bleeding so quickly.
Okay, sir. Thank you, sir.
Another important thing is once a firm contraction and retraction, even you put off the machine, that contraction and retraction sustains for some more time, even for a long time. That's why 10 minutes is enough to create stop bleeding. And 1 hour gap, you make 1 more 10 minutes. Like this, 2-3 times more time, that's enough. You need not apply negative pressure throughout. Another important thing I would like to share, these tissues at the cervical region only get sucked into holes, not at the level of fundus. That is really a God-given gift. If entire even fundal region holes are also sucking tissues, it is difficult to remove and it will not work because there's a differential texture of the tissues. At the fundus, it is a thick and it will not get sucked into the holes. Whereas cervical lesion, these tissues are soft like a cotton. It will immediately get sucked and it will create a closed uterine cavity. This formation of closed uterine cavity is also there in JADA system. They have put one balloon to create a closed uterine cavity. But here I have made simple holes. So automatically it holds the cervix also and it works extremely well. It will not fail. Nowhere the cannula failed till today. In South India, thousands of applications occur every day. Only thing for us is we have to take this North India where lots and lots of maternal deaths are occurring.
Actually, to all, I wish to say that when we are doing physical workshops, so many people actually, like what Dr. Vinod was saying about the rural setting on a one-person practice. Even in a big cities, we are not that close to each other. So we have got so much of the appreciation and the very good experience that we applied Canada and that saved the thing. So it is very ground root experience which we are getting from all the corners, and that's why we always like Dr. Samartha Ram, that very, very simple one-time investment. Just it has to be there in our labor room for adding, and most of that what we say, it is what the people say, it always works, it never fails. So be it is South, be it in Bihar, in Jharkhand, I have found very, very good experience from the people who are using the Samartha Ram cannula. So it is something like to believe into it and to use it, that actually what we emphasize. And Samartha, there are questions where to get, always we get, so please answer in the question answer session.
Okay, right.
So
they want to post questions now or they put in the question box?
Babita, you go ahead. Babita, you go ahead.
Yes, ma'am. So quickly moving towards the next very interesting video session on stepwise devascularization to be presented by Dr. Shashi Kavra ma'am. And for this session, I would like to invite our esteemed chairperson, Dr. Sneha Buyar ma'am. Madam she's got a very impressive CV. She's recipient of so many awards, that is National Individual Award Foxy, Dr. Anandibai Joshi Award, Foxy President Appreciation Award for Public Awareness, Foxy President Appreciation Award for Exemplary Work in Cancer, International MS Signature Award, Lokmat Healthcare Excellence Award, Champions of Foxy 2021, and the Leader Accessor in Foxy Manyata. Madam has more than 300 talks in state, national, and international conferences, 25 articles and chapters in national publications. She is organizing chairperson of so many conferences, be it Criticare Nagpur, Zonal Amogs, Lactacon, BreastCon. Madam has been chairperson of Breast Committee 1921, Governing Council member
22
ICOC, chairperson of Medical Disorder Committee, founder president of Vidarbha ICPAR, and president of Yavatmal Obscene Gynae Society. Madam is a primary investigator in fighting against cervical cancer and co-coordinator for Ankur Project and research on menopause 2018. A very warm welcome to you, ma'am.
Thank you.
Now I would like to invite Dr. Shraddha Paritkar. Dr. Shyam Kumar Sirsam. Sir is Associate Professor at Government Medical College, Nanded, and is President of Akola Obs and Gynae Society. A very warm welcome to you, sir. I would hand over the session to the chairpersons to introduce Dr. Shashi ma'am and to conduct this session.
Thank you so much, Dr. Babita, for that kind and generous introduction. And at the outset, I would like to thank Madam Sadhana Gupta for having us here. A very good evening to all of you. Talking about Shashi, a very dear friend, a very vibrant personality, multi-talented. I have a special affection for her because she was my committee member from North Zone and very active, passionate about her work. And this is one more area where she's very, very passionate about it. She has saved, I think, maybe hundreds of lives, and she has personally actually performed many operative procedure as far as the PPH is concerned, and rest of the CV is here. She's very academic and very sound, I would say a skilled person, and worthy of going into for any academic post, I would say. With this, I wish you all the very best, Dr. Shashi, for your upcoming elections for Governing Council member of ICOG, and the diocese is yours, my dear. We are eager to listen to you.
Thank you so much, and lots of love, Dr. Sneha, for such a kind introduction. And thank you so much, Dr. Sadhana ma'am, Dr. Ayushi, Dr. Babita Shukla, and all the societies of Aurangabad, Akola, Alkuz, Baramati, and Islampur for giving me this wonderful opportunity. I'm sharing my screen. Is it visible?
Yes.
Yeah.
Yes.
Yeah. So we begin with step-wise revascularization. I always say that we have to defeat PPH by converting our nightmare to an expertise. And that can be achieved only by learning the skills. So this is an age-old picture which shows here the uterus with the LSCS wound. And these are the places where we do uterine artery ligation, upper and lower. And this is the place where we ligate the anastomosis of the uterine branch of ovarian artery and ovarian branch of the uterine artery. We never ligate the ovarian artery here. As the word says, it is a misnomer. This is the site of ligation. So coming straight to my video session, this is a video of uterine artery ligation. Bladder pushed down. I'm palpating the uterine artery. The suture of my choice is Vicryl or catgut. 2 centimeters of the myometrium is taken. Needle pass from anterior to posterior. I usually use number 1 or 2 catgut or Vicryl. Now needle taken out through the avascular area in the broad ligament from posterior to anterior. There should be 2 turns in the first knot to make it a surgical knot. Squaring of the knot is a very important component. Distal ligation is 2 to 3 centimeters below the proximal ligation. Same method. First pass the needle from anterior to posterior. Then from posterior to anterior. Fan out the broad ligament, find out an avascular area. Go from posterior to anterior. When we pass the needle through the avascular area, we do not puncture any other vein or vessel. And just tie it like this. And it is to be done on both the sides. Now I'm showing you the ligation of the ovarian branch of uterine artery and uterine branch of the ovarian artery. The anastomosis, it lies here. This video is shared to me by my friend, Dr. Soma. So here, 2 centimeters of the myometrium is being taken. You see, the incision, the prick is here, not here, because it will bleed a lot when we prick it here. So this is the place where we prick. Needle taken out from anterior to posterior side. A vascular area again found in the broad ligament. And the anastomosis lies in between the 2 bites of the needle. We can easily save the big plexus of veins nearby. And this is how we ligate the utero-ovarian anastomosis. And it is to be done bilaterally. Now I'm coming to the internal iliac artery ligation. FIGO, in its 2022 guideline, clearly says that every obstetrician must learn internal iliac artery ligation in order to save the patient from postpartum hemorrhage. And you believe me, I've done more than 100 internal iliac artery ligation, and I tell you that except in one case, which was already very sick, came in shock, which was irreversible. All other patients we could save with internal iliac artery ligation. So this is a life-saving operation. And if you learn this technique as an obstetrician, then you are not dependent on surgeons or other specialty persons. 2 obstetricians can do very easily. So coming to the anatomy classes of first year, this is abdominal aorta, the biggest artery in our body. At the level of L4 and L5, it divides into 2 common iliac arteries. And each common iliac artery in succession divides into external iliac artery and internal iliac artery. External iliac artery has a bigger lumen and it is lateral. Internal iliac artery is posterior-medial in its position. So we talk about these 2 inverted Ys, which is made by common iliac artery division. So this is one side of this part of this. This is the external iliac artery. This is internal iliac artery. This is common iliac artery dividing into these 2 arteries. And internal iliac artery, as soon as it originates, it gives a posterior division. So we have to ligate this anterior division. It is approximately 3 to 4 centimeters below the origin of the internal iliac artery from the common iliac artery. And you can see that the veins are almost opposed with the artery. So we have to take precautions of these veins. So how internal iliac artery works? Bilateral ligation results in 85% reduction in pulse pressure, 50% reduction of blood flow. It converts an arterial flow into a venous flow, and thus it facilitates coagulation. Bleeding is definitely reduced and life is saved. Initially, it is technically difficult, but it has not a long learning curve, and one can practice it in first in gynecological hysterectomy cases by routinely opening the retroperitoneum. And then after doing for 3 to 4 times in gynae hysterectomy, one can shift to OPS cases. So there are two approaches of performing internal iliac artery ligation. One is anterior approach, in which we open the retroperitoneum. Here the word retroperitoneum means opening one of the layers of the broad ligament. And we start it from the cut end of the round ligament if hysterectomy is done, or make a nick in the peritoneum of the round ligament and extend it laterally to the lateral pelvic wall. And I usually prefer anterior approach, and it is definitely easier. And another is posterior approach. Here we push the uterus anteriorly, we palpate the sacral promontory, and we open the retroperitoneum 2 centimeter below and 2 centimeter lateral to the sacral promontory on both the sides. Here again we open the retroperitoneal space. So these are my two companions of performing internal iliac artery ligation. This is the mixture forceps, also called right angle forceps, because it is bent at right angle. And this is the silk thread, which I make it double like this. When silk is not available, I use Vicryl. So this is the teaching model which I made for my students. Why it is required? You know, when doctors assist you, junior doctors assist you while you are performing internal iliac artery ligation in a grave, deadliest emergency, then do not understand the structure and they can't assist you well. So this came to my mind that I should make a model and should teach them what is basically the anatomy of internal iliac artery ligation. So I'm just playing this video. This is common iliac artery. This is external iliac artery, which is later on continued as femoral artery. This is internal iliac artery, and we have to ligate the anterior division of the internal iliac artery. When we apply pressure on external iliac artery and press it, then the femoral pulse will go. Normally in the pool of blood, this posterior division is not seen. If I place my thumb here, then the length of my folded thumb is around 3 centimeters. So I just put my thumb here at the beginning of the bifurcation, and around 3 centimeters, this is the place where I can recognize the internal iliac artery needs to be ligated. This is right angle forceps, also called mixture forceps. It is bent at 90 degree and it has a point, but it is not sharp. I use only this instrument for dissection and for ligation. Internal iliac artery, this is internal iliac vein. They are enclosed in a sheath. So in order to ligate the internal iliac artery, we have to remove the part of the sheath. Now I do not remove the sheath along the whole length of the internal iliac artery. I remove the sheath only at the place where I need to ligate the internal iliac artery. And look at the movement. Here I am separating the sheath because this is my proposed site of ligation, and my movement will be like this, parallel to the sheath. Never do like this because it will end up injuring the internal iliac vein below, and that will be a massive bleeding. So I am separating it like this. I have already made a place here for ligation, passing the right angle forceps from lateral to medial, and gently I will open it. This is the double thread. I will get hold of the loop, and just gently I will come out like this. This movement is very, very gentle. So this is the basic anatomy and basic methodology. I will cut this and make 2 threads. Great. And this is another thread. See, this is plain and this is another thread. So look at the technique of applying ligature. I have taken hold of one ligature. I am not pulling the artery. If I pull the artery, then it will just get torn and will come in my hand and there will be massive bleeding. So I am giving respect to the artery, going up to the superior surface of the artery and just applying knot. This is one turn and this is second turn. And I have tied it here. In the first knot. Place the knot on the very gently surface. I applied the second throw. Never pull the artery. And again, never pull the threads. I applied the third throw. Without pulling the artery, I myself cut this. Just without giving any pull on the suture, I cut this. I'm just putting. This is common. So this was a case with 26-year-old primary gravida with full-term pregnancy. She was initially booked at one facility. Then she had antenatal care at one Anganwadi center. She started having labor pain on 23rd November and rushed to 3rd hospital at night. There she went into obstructed labor. She was taken to another 4th private hospital and undergone an emergency cesarean section for 2nd stage arrest under spinal anesthesia, and note the time at 8 a.m. in the morning. She had an episode of PPH after 2 hours 15 minutes, and which was managed medically by the doctor. doctors over there. Then she had another second episode of postpartum hemorrhage at 12 to 30 p.m. and she went into shock. So these doctors took her to emergency operation theater, and there under sudden anesthesia, left retinal cervical tear was repaired and the one tear was extended up to the posterior wall. She was given 4 units of PRBCs, 4 units of FFP, and 2 units of platelets that time. And then patient became stable. Then at 7:15 p.m., after 11 hours of delivery, the patient again went into shock. And this time she was resuscitated, referred to me with 5th unit of PRBC on flow. So by that time, 11 hours passed and she received 11 to 12 units of blood and blood products. So when I received this patient, her pulse was 146 and BP was 104/60. In one instance, it looks a stable BP, but shock index, if I calculate the shock index, it was already more than 1. That means patient was in shock. There was bleeding, uterus was contracted. I wasted no time, not even a second, in exploring from the vagina, and I just opened the abdomen by a longitudinal incision in my emergency UT. What could I see? There was a broad ligament hematoma, massive, which extended from the fundus to the lower part and involved the whole of colpos. And there was a massive hematoma on both the sides. So I had to, the uterine artery was retracted. I had to perform an obstetric hysterectomy in that case. But after obstetric hysterectomy, the patient had oozing in the pelvic, whole of the pelvis. So I took a decision of performing an internal iliac artery ligation. This was a real case situation, and we just see the video. This is the cut end of the round ligament. I'm making an incision in the anterior peritoneum, which is called retroperitoneum, from the cut end of the round ligament. This is round ligament ligature, and cutting and visualize the structures below, saving them, only cutting the superficial layer of the peritoneum. I'm going up to the lateral pelvic wall. You just see how I'm cutting the peritoneum, taking care of the structures below and opening the peritoneum. This is the retroperitoneum. Now I've kept my instruments, and only with the help of my 2 fingers, I'm dissecting the loose areolar tissue. This is the ureter in the medial flap. This is common iliac artery. This is the retroperitoneum opened, loose urinary tissue separated, ureter in the medial flap. Common iliac artery, external iliac artery, and internal iliac artery. You can recognize the inverted Y very easily. Common iliac artery, external iliac artery, internal iliac artery. And this is ureter in the medial flap. Now, so it is very important to recognize the inverted Y. So now I'm making the dissection more clear. Now you see common iliac, internal iliac, external iliac. Now I'm palpating the external iliac artery and at the same time femoral artery. If there is a change in pulsation, then this confirms that this is external iliac artery. Now I'm pressing the internal iliac artery and there is no change in the pulsation of the femoral artery. Now the mixture forceps is in my hand and I'm dissecting at the proposed site. This is 3 to 4 centimeters below the origin of common iliac artery. Because here we cannot see the posterior division. You see how I'm doing dissection with the help of the mixture forceps and cutting the sheath which encloses both the internal iliac artery and the vein below. And my direction of this mixture forceps is parallel to the vessel. Just see how I'm cutting. You can see here below the bluish structure is vein, and I'm saving the vein nicely. This is the internal iliac vein. This is the internal iliac vein, and this is the artery. Now I made the dissection, passing the right angle forceps from lateral to medial. Always remember the word lateral to medial, because if we introduce from medial to lateral, then it will hit the external iliac vein. The double loop is already ready. It has to be kept ready beforehand. And just I've taken hold of the loop and gradually taken out. And so with one suture, we can make 2 sutures. This is the reason why we use a double thread. I'm very gentle at every procedure, at every mechanism of action. I've cut the thread, and now with one thread, we have made 2 threads. So this prevents us from one more insertion of right angle forceps. Now I'm separating which one is playing with which one. The movement of mixture forceps is always from lateral to medial, because if we insert from medial to lateral, then it will hit the external iliac vein of that side. On both the sides, the movement is lateral to medial. I always do internal iliac from right side. Now, after separating the thread and Seeing their continuity, I'm applying the knots. There should be 2 turns in the first knot, as I've demonstrated in my video on the model. I'm not pulling the thread, taking my finger below in the depth, bending my back, bowing my head in front of the artery and pressing the knot on the superior surface of the artery. Remember it, here you have to bend, you cannot pull. Again, I'm taking my finger below and doing it. So you have to bend your finger, you have to bend your back, and you have to bow your hand in front of the artery. That artery, dear artery, you are the best artery of one of the biggest artery of the body. So I salute you. And regarding ureter, I always say ureter lies in the medial flap. Very good structure. It says that I am lying in the medial flap. You do your work on lateral side. So one suture is already in place. You can see the suture here. This is the suture. Now the second suture will be applied 0.5 to 1 centimeter away from the first suture. Do you see how I am applying it? 2 turns have been taken in the first knot. Knot is being placed in the depth of the retroperitoneum on the superior surface of the artery. My finger has gone up to the superior surface of the artery. I'm not pulling anything. So never afraid of ureter. Ureter always lies in medial side and you are working on lateral side. So second suture is applied. So now you can see very well. This is the internal iliac artery with 2 ligatures. You can see the bulge in between 2 ligatures. This is internal iliac artery. So this is the main mistake which people do. It is not to be introduced from lateral to medial side. This is the right technique, passing the mixture forceps. And when it is passed, it grazes through the artery because the vein is below. The bigger the artery, the thicker its wall. The bigger the vein, the thinner its wall. So these are my own tips after performing so many operations, that you open the retroperitoneum from round ligament to infundibulopelvic ligament, going up to the lateral pelvic wall. Then for the posterior approach, you open the retroperitoneum 2 centimeters below at 2 centimeters lateral to sacral promontory on both the sides. I've shown you methods. Then once you open the retroperitoneum, you do only finger dissection. No instrument should be in your hand. And you always locate the bifurcation. It is an inverted Y, which you must recognize. Unless you see the inverted Y, you should not proceed. Then recognize internal iliac artery as a medial structure, not causing any change in femoral pulse. And the movement of mixture forceps is always from lateral to medial, and lateral to medial. Careful not tying in the cavity. I have demonstrated nicely. 2 ligatures should be 0.5 to 1 centimeter apart. And last but not the least is always do bilateral, because the literature says that the chances of relaparotomy and morbidity increases when we do unilateral ligation. So thank you so much for giving me this opportunity, and I seek your valuable vote for ISOG Governing Council membership. Thank you so much.
I would request our chairpersons to give their comments. Dr. Sneha, ma'am.
Yes. Is Dr. Sham Sesam here? Achha, he's not seen, I think. I have already said Shashi has, she has a passion for this subject, and it's really worth listening. Rather, I would say we have to learn a lot from her. Common obstetricians can easily follow what she's telling. She actually demonstrates how to do the procedure. So I think it was an excellent video presentation and demonstration as well, Shashi. So with this, I think I just say I don't think there are any comments to make, but it was an excellent presentation. And I too seek all of your support and your precious votes for my candidature as Foxy Vice President from West Zone. I can see all my societies joined here, and Chief guest Milin Shah, Parag Biniwale, and the AMOX President Rajendra Singh Pardesi sir and Madam Sujata Darvi, and all the societies of Aurangabad and Islampur, Akulus, Solapur. So I'm very happy to chair this session along with and Thane. Hi Supriya. I can see Dr. Supriya Arwari here with a very active, vibrant personality, multi-talented personality. So, well, I just thank all of you to invite me here, and thank you, Madam Sadhana Gupta, for having me here once again. Thank you.
Thank
Over
you,
to
Sneha,
you.
and best wishes. Best wishes.
Thank you, Madam. Thank you so much. Hello,
Do we
Dr.
have
Aparna.
Shyam sir with us?
Supriya.
Shyam sir? Sir, are you there? I think he had put a comment. He's unable to join because of the link or something. We gave him a separate link. I don't know whether he joined.
I don't see him actually.
That's what. So, man, that was a wonderful session. Thank you to our speaker and chairpersons for giving your valuable time. Now, moving towards our panel session, we have a wonderful panel on difficult case situations in PPH. Our moderators for this panel are Dr. Dolly Mehra. She's president of Ratlam Obs and Gynae Society. She's organizing chairperson MP State Conference, Zonal Coordinator Foxy 2019, Joint Secretary MPOX 2019, faculty in various national and state conferences, peer reviewer for Jogi. She has got award for Champions of Foxy Award, Durusha Youth Trophy for Best Activities in Adolescent Health to Ratlam Obs and Gynae Society, Wonder Foxy Award 2019, Champions of Foxy President's Appreciation Award to Ratlam Obs and Gynae Society under her leadership, and the Nari Swast Pehal Foxy Appreciation Award. Her areas of interest being high-risk pregnancy, infertility, and vaginal surgeries. A very warm welcome to you, Dr. Dolly. We have as co-moderator, Dr. Aditi Rathore. She is consultant at Rathore Nursing Home, Jaora, member of Organizing Committee AMOGS 2018, Secretary ROGS at present. She has got the PMSA Award 2019. She speaks at national and state conferences and participated in various webinars. Her areas of interest being obstetrics and fetal medicine. A very warm welcome to you, Dr. Aditi. As panelists, we have expert panelists. We have Dr. Gorak Mandrukar. Sir is consultant reproductive medicine, Islampur, Director Angel IVF Clinic, Pune, member Task Force National Policy on PPH by Government of India. He invented the Gestosis Score, an affordable Indian innovation for screening pre-eclampsia. That is really wonderful. He has drafted guidelines on hypertension in pregnancy, Foxy ICOG Gestosis, 4 books, 9 publications, and more than 500 lectures. Very commendable. And Sir has developed medical Android apps on HTTP Gestosis Score and Cross11. A very warm welcome to you, sir. We are really privileged to have you as an expert panel. As panelists, we have Dr. Aparna Rao. She is practicing OBGYN since 25 years and recipient of Young Scientist Award at AICOG Hyderabad at Siliguri, recipient of Young Gynecologist Award at Asia Oceania Conference, Malaysia. A very warm welcome. Then we have Dr. Supriya Arwari. She is consultant OBGYN and infertility specialist practicing at Supreme Hospital, Bhiwandi for last 20 years. She's National Coordinator Foxy Adolescent Health Committee, Chairperson of Association of Maharashtra OBGYN Welfare and Cultural Committee 22-24. She's Secretary of Thane Obs and Gynae Society, Managing Committee Member and Program Committee Chair of Association of Medical Consultants of Mumbai. She's past President of Indian Medical Association. She has received Dr. Anandibai Joshi Award for Meritorious Service by Female Doctors and won the title of Mrs. Iron Lady in Mediqueen Mrs. Maharashtra Beauty Pageant. Very nice. She is recipient of AMOGS V for Stri Puraskar by the Honorable Governor of Maharashtra. A very warm welcome to you. Then we have Dr. Kavita Kamble. She is Director Krishna Cardiac Maternity Care. He's working since last 15 years as high-risk obstetrician. She's clinical secretary of OGS, colposcopy since last 5 years, and trained with Dr. Priya Ganesh Kumar in colposcopy. She's received fellowship in IVF in Delhi, PK Birla Institute. A very warm welcome to you. Then we have Dr. Nitika Raghuvanshi. She was awarded with University Gold Medal for her outstanding performance in post-graduation. She also acquired DNB. She did various training program in NDVS laparoscopy, colposcopy, and joined as assistant professor at Government Medical College, Akola. She was promoted to associate professor, now working as unit head in 2015. She is MMC accredited speaker and has interest in colposcopy and high-risk obstetrics. A warm welcome to you, Dr. Nitika. Then we have Dr. Mansi. Dr. Mansi is consultant obs and gynae and laparoscopy surgeon at Debrikat Medical Center, Akluj, IVF consultant at Akluj Fertility and Test Tube Baby Center, and she's clinical secretary of Akluj Obs and Gynae Society. A very warm welcome to you. Then we have Dr. Revati Rani. She's consultant high-risk obstetrician and gynecologist at Apex Hospital and high-risk obstetric center, infertility specialist at Akluj Fertility and Test Tube Baby Center. She has done a certified laparoscopy. She's a certified laparoscopy surgeon and hysteroscopy training at Nawale Hospital and received IVF training at 21st Century Hospital, Gujarat. Very warm welcome to you. And finally, we have Dr. Swarupa Iyer. She is consultant OBGYN and fertility specialist and medical legal advisor. That's very important in the current scenario. She's secretary TOGS, member of EMLC Foxy. She's peer reviewer for Journal of Obs and Gynae of India. She's part of legal team of Apex Insurance and practicing since last 26 years. Okay. So very warm welcome to our moderators, our expert panelists and our panelists. And we look forward to a very, very interesting session.
Good evening. With my great respect to Dr. Sadhna ma'am, Dr. Milind Shah, Dr. Parag Biniwale, Dr. Rajendra sir, Dr. Jayashree More, Dr. Vinod, Dr. Sneha Bhuyar, and Dr. Babita Shukla. I am grateful to Aurangabad, Akola, Aklaj, Baramati, and Islampur societies. And I welcome my expert panelist, Dr. Gorak, my panelists, Dr. Aparna, Dr. Supriya, Dr. Kavita, Dr. Nitika, Dr. Mansi, Dr. Reti, and Dr. Supriya. So here we are today to discuss atypical case scenarios in PPH, right? And these are really atypical cases. So let me go directly on to the case number 1. So case number 1, she's a primary gravida, 32-year-old female, booked and investigated, had spontaneous conception, past history of renal transplant 3 years back, reported with leaking at 36 weeks gestation. On examination, her GC is good, well-oriented, pulse 100 per minute, BP 150/90 millimeter of mercury, 36 weeks on per abdominal examination, 36 weeks cephalic, fetal at 140 beats per minute. PV is 1 finger loose, not taken up, leaking present with meconium. CTG shows beat-to-beat variability more than 10, but there is no acceleration in 30 minutes. Past history, there is a renal transplant 3 years back for chronic kidney disease. She's on immunosuppressants, preconception counseling done by nephrologist, proper antenatal care taken, essential hypertension with superimposed HDP managed with labetalol and nifedipine. Dopplers were within the normal range and nephrology consultation taken off and on. Investigation showed hemoglobin of 10 gram per cent, BT-CT prothrombin time and liver function test normal, serum creatinine 1.3, blood urea 35 milligram per deciliter. Platelet counts were 80,000 per minute. Delivery, LSCS done for fetal distress, AMTSL done. Female child delivered with good Apgar score, kept under the pediatrician care. Care taken for proper hemostasis, but post-operatively, 30 minutes after the cesarean, she, in spite of having medical management, there was bleeding. and estimated blood loss was 800 ml. Balloon tamponade done. Medical management continued. Fourth stage monitored in ICU. Input-output chart maintained. 2 units of fresh frozen plasma and packed cells arranged. Balloon tamponade gradually released after 24 hours, and she was discharged 4 days after doing the renal function test. So my first question is to Dr. Aparna. What preconception counseling will you do? And was it justified in this particular case? What is the ideal time for conception? Dr. Aparna?
Ideal time for conception in a case of CKD, ma'am?
Yeah. And renal transplant. She has undergone a renal transplant because of CKD.
Yeah.
So what is the ideal time for conception? And is preconception counseling justified?
1 year of transplant.
After 1 year of transplant, if the renal functions have come to the normal values,
Yes.
then can conceive. But she is on immunosuppressives. So we should counsel her for prevention of infections like asymptomatic bacteriuria, which can turn into UTI. So prevention of all these things and hygiene should be explained to her. And should be explained that she is likely to develop hypertension and other diseases, being a high risk primary gravida. And she should follow up. I should answer the next questions also.
Yeah, there are 2 questions, right? I'll ask the other panelists. So the ideal time for conception is when the serum creatinine is less than 1.5 milligram per deciliter. The protein excretion is less than 500 ml per 24 hours. She's not on fetotoxic medications, and the immunosuppressant doses are stable and at a maintained level. Then we can say that the prognosis of the ongoing pregnancy will be good. So now the next question, Dr. Supriya, what antenatal care and what care will you take during delivery and LSCS? Dr. Supriya.
Yes, ma'am. I hope I am audible.
Yeah.
Yeah, madam, at the onset, let me thank the organizers for giving us all this opportunity. And frankly, with all those wonderful lectures, most of our job is done as panelists with their really beautiful presentations. Coming to this case, antenatal care, first and foremost, we should be doing this as a team approach. We should have the nephrologist, maybe, the physicians in tow, the pediatricians involved in managing her. Like you have said, we should be counseling her. We should be monitoring, apart from her routine antenatal stuff, we should be monitoring her renal function test. If she is on any drugs which can be toxic to the baby, then we, in consultation with the attending nephrologist, we should switch them to some safer options. With immunosuppression, we should be extremely careful about her developing any infection. In fact, it could be just a plain upper respiratory tract infection, a viral infection, or a UTI, maybe vaginal infection. It is bound to get flared up. So we should be, we should also counsel her to catch the warning symptoms and approach us on time. Maybe we'll be a little more liberal in using antibiotics or antiviral agents in her case. And of course, we'll keep our physician friends in the loop.
What about fetal monitoring?
Fetal monitoring, I believe, madam, we should do close fetal monitoring for all patients, high risk or otherwise.
Yeah.
And whatever we routinely do, the NT scan, the anomaly scan, the 7th month scan. Now, these are the patients usually in 7th month onwards, they can develop IUGR, they can develop oligohydramnios. So maybe we would do the fetal Doppler a little earlier, maybe 32 or 34, because she's also a candidate for an early delivery if required.
Yes.
So at 32 weeks, maybe instead of 36 or 34, 36, we will do an early Doppler scan, repeat a Doppler probably every 2 weeks if it is normal, and maybe weekly if baby is already showing compromise. She is on immunosuppressant, so I would really like to know from the experts, actually, the Dr. Bandapurkar is here, whether we should be giving her steroid injections at 32 weeks to, accelerate the fetal maturity, because it's quite likely she may land up with an early cesarean or early delivery. She should be booked in a tertiary care center where there is facility for transfusion, where there's facility for NICU and facility for ICU, admission. So all these things we should be careful. When we plan a cesarean, the anesthetist should be one of the senior most that is available in the institute, and with the due, consent, high risk consent for anesthesia.
Thank you so much for elaborating it well, Dr. Supriya. Dr. Gorak, can I ask you this question? Can we use steroid for lung prophylaxis?
Definitely. At the outset, I thank you all for involvement. And now answering to the question that yes, most of the times, these patients are already on steroids. That is number one. Second thing, there is no contraindication for the steroids for the fetal lung maturity. Only thing we have to understand, most of these renal transplant patients, they have either diabetes or hypertension.
Yes.
So we need to be very careful. Because of that, those immunosuppressants and especially the added steroids, usually they land up in diabetes after maybe 1 or 2 years of the renal transplant. So in that, here I will advise you use whatever Dex or Beta. Only thing that we have to use 6-6-6-6 protocol, because here we do not want to increase blood pressure and blood sugar. So that we have to take care of. And another thing, because she is on immunosuppression, so with little bit higher dose of steroid, again we have to be very careful regarding the infection, keeping the TLCs, keeping the CRP monitoring. That is number one. Another important thing, everything was told by Dr. Supriya beautifully, that how a delivery process should start. Money right from the tertiary care hospital and all. But one thing here I would like to focus on, because in those questions I am not seeing that, and that is we have to keep a different type of blood component for these patients. So, Dr. Dahlia, is it there in later on, or should I elaborate right it now?
No, sir, you elaborate, sir.
Great. Because usually now what happens, whatever routine FFP, the fresh frozen plasma or whatever blood components we are using, even PCV, they are with leukocytes. So for renal transplant patients, we have to use leuko-depleted pressure, packed volume, PCV. That is very important, because later on, otherwise, they will end up in fulminating infections. So that we have to be very careful. Antigen antibody reactions and all, they may occur. So here nephrologists will tell us, but we have to be very careful regarding using the blood component.
So
another last thing here. Yes, madam.
Yes, sir. No, sir. Please go ahead.
A very important thing that everybody should keep in mind, that there is no auto-regulation of the kidney. It is a denervated kidney. So in case of postpartum hemorrhage, the per se response from the kidney will almost be nil. So because of loss of auto-regulation, in the management of PPH, whatever we will give, only on that patient is going to survive. So we have to be very careful. Otherwise, even another thing I would like to here emphasize, okay, this patient is with hypertension. But if patient doesn't have even hypertension, still the vasospastic agents like metharzine and all, ideally they should be avoided here, because they may cause a renal artery spasm. And immediately these patients, they may go in ATN, acute tubular necrosis. So all these precautions we have to take. Just to add what Dr. Supriya has elaborated very well.
So, sir, yeah, it is very important that the steroid which we are going to give, the patient should be admitted, and then under monitoring, the steroid should be given, and should be given at a smaller doses, that is 6-6-6, that should be given. And here also in this case, we didn't use metharzine or prostaglandin, it was only oxytocin which was used. And you have already answered the third question, the fifth question. What should be the threshold for the amount of blood loss? And in this patient, in spite of having 800 ml of blood loss, balloon tamponade was done. Whether it was justified? Can I ask Dr. Kavita?
Madam, just one more point, that this is ideal patient for carbetocin. It's a beautiful drug, very,
Yeah.
very safety profile is very good. And I think this is one drug, a place where carbetocin, should be encouraged. Why I'm just bringing it up is that we should understand that carbetocin and oxytocin receptors are common. And therefore, if we have to give carbetocin, we should not be loading her with oxytocin. Give her carbetocin. And if we want to give a oxytocin drip, we should give it minimum after 40 minutes of the carbetocin dose.
Yes.
Otherwise, the receptors are going to be flooded, and then oxytocin or either where carbetocin will not act. That is one point.
One thing, Supriya, I will like to respond to your comment, and one more point. Actually, carbetocin as for the active management of third stage of labor. So if we have given carbetocin as a MTSL, then the oxytocin is not going to actually help. So as per see, the carbetocin for management of PPH is a little bit question unless we have not given it as a MTSL. If we have given as a MTSL, that no second dose.
Yes.
So that is very important point, Supriya, have you taken, because that is a lot of gray areas where the people are not there.
Yes.
If you have given a MTSL, then there is no need to give further oxytocin or the next dose of carbetocin. It is not to be repeated. And one point, Dolly, I will like to say, it is a little bit beyond postpartum hemorrhage, that if we do cesarean section in kidney transplant, the safer choice is the vertical incision, not the transverse incision, because the transplanted kidney is in the lower pelvic area, and there have been real reports that you inadvertently injure the kidney and find the transplanted kidney, and the second thing is a lot of adhesion in that area. So this is also very important point, that the incision safer and the better choice is the vertical incision in the renal transplant.
Yes, ma'am, I was coming to that. I would like to ask Dr. Gorak, I'm going away from the topic. Will we allow normal delivery in this patient? And what precautions to be taken during cesarean? Dr. Gorak, I would like to ask this question. But before that, sir, the take-home message would be that in such patients, if you are using carbetocin, use during AMTSL only carbetocin and not oxytocin. Of course, we used oxytocin, but if we have the availability of carbetocin, then for AMTSL, you are going to use carbetocin. Dr. Gorak, now to you for my question, whether we will allow her for a normal delivery, not in this case, otherwise, and what precautions to be taken in such a patient during cesarean?
Okay. There is no absolute contraindication for normal vaginal delivery, we will say.
Yes.
In case of renal transplant patients. It is very clear.
Yes.
Second thing, only for offset indications, we have to go for cesarean section. Third thing, as what Dr. Supriya and Sadhana Madam has said, we have to take all the precautions regarding institute to methodology. Per se, regarding cesarean section, right from incision, right, that is as she has rightly said, ideally it has to be the vertical incision to enter the abdomen, because again, many a times, because as I have already mentioned, because of loss of autoregulation and all, these patients are more prone to develop PPH. Another thing, because of their hypertension and diabetes, again they are more prone to develop PPH. Another thing, there are lots of already adhesions are there. Third thing, though some may not agree, but really the approach to the uterus will be faster in vertical than easier and faster than the financial. So that we have to take care of. Though many of you may not agree, because you all are doing very fast cesarean sections with financial right now. But when we want an elaborate view, easy view to manage any emergency situation, vertical incision is always better. Another thing during cesarean section, as he has already mentioned, usage of carbetocin, that's very important. And actually here one has to be very careful regarding the delivery of the uterus outside the abdomen, because here again, there can be undue pressure or there can be undue handling of the recently operated kidney or that fossa. That we have to take care. Many times it happens that most of the doctors, they take the mops and they put behind the uterus without seeing all these things. So in such situations, we have to be very careful that already there is a problem. Already there is some operation which has gone, but it is being done, and then we are doing these things. So all these things we have to be very careful and keeping in these minds, then one has to go. And last thing here I would like to say that a neurosurgeon or has to be there on call, or at least a phone call should be given to him that "Okay, I am operating on so and so patient, so help may require for the adhesions or all those things if go wrong." Over to
Thank
you.
you, sir. Thank you, sir. So coming back to my question, what should be the threshold of amount of blood loss, and was balloon tamponade justified? Dr. Kavita Kamble, can I ask you these two questions?
Yes, ma'am. Good evening, everyone, all the esteemed panelists and the judges and everyone here. I'm so glad to be part of this webinar. Yes, ma'am. Coming to the question, normally when we say there's a postpartum hemorrhage in a section, we say that at least 1000 ml blood has to be lost so that we can label it as a PPH. But in this case, since we want to be on the safer side and we don't want the patient to go into acute renal failure or any other crisis, at 800 ml also, we will go for this balloon tamponade, and we will prevent the blood loss as early as possible. So the next question, as you say, the types of balloon, there are various types of balloon. Usually these are very cost effective, and depending upon the reusability, there are different types of balloons which are usable. One is the condom catheter, which is very commonly used in rural areas where we practice. We have used this many times because it is very inexpensive. You just have to blow it and keep it, and so that you apply pressure. There are others like ESM and UBT. There is another like the Bakri balloon, which is also very common nowadays. This is also one which we have used, which is a 24 Foley's catheter with a French diameter of 24, and which is 54 centimeters long silicone tube, and that has to be introduced, and it is very effective method. So I had asked this question. So what was the difference between a Bakri balloon and the SR cannula which we can use? Dr. Sadhana madam has very well answered that the concept is different. In SR cannula, you're using the contractions and and your contractions and causing the contractions and relaxations, that is controlling the PPH. But in Bakri balloon, you're just applying pressure. So that is a negative pressure is not applied in Bakri balloon. It's just the pressure which is applied. So in all these types of balloons can be used. The most common is the Bakri balloon, and there's one more called Ilavi. I think I hope the pronunciation is right. And
Right.
Ilavi, which is like a water-filled balloon, and it has to be placed inside the just as water is placed inside that balloon, and it is placed in the bag. And once the uterus contracts, that ball is expelled out. So that is one more way of controlling the blood loss in such patients. So I think it was justified even at 800 ml, though we would be more aggressive if the blood loss was more than 1000 ml in normal cases.
Okay. Thank you,
I
Dr.
would like to add, ma'am, and I would like to add something that while we are managing this PPH, we should see that the minimum renal perfusion pressure of 80 millimeter of mercury is maintained. Otherwise, the kidneys go in ATN.
Yes. So
And
that is why the early decisions, right?
Yeah, oxygenation of patient is very important.
Perfusion has to be maintained, right?
Yeah, 80 millimeter is the
Thank you,
minimum.
Dr. Kavita, and thank you, Dr. Aparna. So what should be the post-delivery follow-up, and what should be the contraception advice? Is it needed or not? Dr. Nitika, can I ask you this?
Yeah, thank you, madam, at the offset for allowing me as a panelist in this session. The post-delivery follow-up should be a little frequent rather than the general follow-up. And in this follow-up, we should be concerned on the part of infections, like postpartum infection should be addressed properly, because these are the patients who are already on immunosuppressant drug. So the chances of getting infected when they're going to home will be more. So they should be given proper counseling regarding the postpartum care or PNC care of and also assessing about the nature of lochia which they're passing. the smell and all, and they should also be having a repeat follow-up for us if they feel any kind of suspicion regarding that, or episodes of fever if they are suspecting. So they should address it promptly to us. Regarding contraception, definitely the need of contraception is very much in these cases, because we do not want them to become pregnant again and again. And even the process of MTP will be risky for them, because they have to undergo some kind of anesthesia and all. So that is going to put again a burden on the transplanted kidney. For them, the barrier methods are good choice, but at the same time, the failure rates with barrier method is quite high. So some of them advocate even a newer generation contraceptives, newer generation IUCDs, which are hormonal ones. But the problem with them is the risk of infection to some extent. If patient is educated enough and able to take a proper care and a follow-up, this can also be given as a good justice to her. And low dose oral contraceptive pills can also be an option, especially progesterone only pills. So they will be taken care of these patients without affecting much on their transplant part.
I think injectable contraceptive is a better choice for this patient. Injectable.
Thank you, Dr. Aparna. Can I ask expert opinion about Dr. Gorak regarding contraception in these patients?
Yes, as Dr. Aparna Madam has rightly said, the injectable contraception will be the better option, because again, there is less chance of infection. Second thing, less chance of, because there is no estrogen, whatever we are using in DMPA, so less chances of hypertension or related problems. Then that's why it is better. And yes, ideally injectable when a DMPA will be the best option. Some may say Mirena, some may say, but again, I will advise here no, because again, we are introducing something inside the uterus.
Right.
This patient very much high risk to develop infection. So absolutely injectable contraception will be the best, or vasectomy.
Yes, yes, sir. Welcome.
I will go for vasectomy, because here husband will get immediately counsel that Baba, अभी तेरे लिए इसने इतना सब कुछ उठाया है, now ये तू थोड़ा सा vasectomy कर ले, बस आगे का काम हो जाएगा. That will be the better option.
Thank you.
Shall I add something here?
Yeah.
We were talking about application of SR cannula, no? Waiting till 1500 ml blood loss is not the correct way. My suggestion, no, if you, even I suggest you don't wait PPH to occur while you're conducting a delivery or while doing a cesarean section. If you see excessive bleeding, you apply it. In fact, my suggestion in peripheral centers with suboptimal facilities, you apply suction cannula for every normal delivery, every cesarean. In a small settings where a CHC or a small nursing home, my suggestion is apply cannula for every patient. Hardly application of cannula takes 45 seconds, less than a minute time. Once the blood loss is not there, no, you'll be very comfortable, very cool, and there will be no need for blood transfusion. And many things are advantageous, and you can't compare performance of SR cannula with balloon, any type of balloon, because cannula stops bleeding in 2 minutes time, and it is very, very effective. And now entire South India is using now, every day at least 1000 applications are going on. Not a single case we have failed, cannula failed. Cannula is failing means they have not applied properly, that's all. So my suggestion, no, that's the thing I would like to share with you. And don't wait till the 1500 blood loss. Even don't permit 200 blood loss. If you see that is excessive bleeding is there, just apply cannula, and all of us will be comfortable, and so many things we can avoid. Blood
Thank you, sir. Thank you, sir.
Thank you very
so
much.
the important take home.
One thing, Dolly, also I will say just a caution that sometimes there are reports, it is that after delivery, there is a graft failure in few percentage of cases. So these patients really need a very good follow-up after pregnancy. So this is something what we should do beyond.
Thank you,
because of the reason behind it, we have to be very careful that there are HLA specific antibodies, and especially these are the pregnancy induced HLA antibodies. So this is a response that we have to be very careful.
Yes.
So
the important points are preconception counseling is essential, antenatal care very important, particularly screening for anemia, eclampsia, GDM, IUGR and UTI, serial Doppler assessment for fetal well-being, low threshold for diagnosing PPH in such patients, vaginal delivery is not contraindicated, a multidisciplinary work, and impact of pregnancy on long-term allograft function has to be taken care of.
Madam, I just wanted to make a last point. Can I? See,
Go ahead.
we were talking about low threshold for PPH, right? In this patient, we had blood loss of around 800 ml. I feel, actually, frankly, I have not managed any of the renal transplant patient, but I have managed one liver transplant patient. So generally, their immunocompressions are almost same. So what I was told when I was managing that patient, that these patients are more prone for low platelets. They're always in a state of thrombocytopenia. And even this patient had very low platelets. So all these patients are going to have these platelets in a condition of thrombocytopenia. So always expect that they are going to have some bleeding problem, in spite of you stopping everything prior to delivery and everything. So even maybe less than 800 ml should be our threshold. And as sir said, prophylactically start treating for expecting PPH. Like, don't wait for bleeding to occur. Probably that is the way to manage the third stage more actively than what routinely we do. And thrombocytopenia probably is a part and parcel of their pregnancy all the time. So, and in addition to tubular necrosis, they are more prone for renal cortical necrosis, because with thrombocytopenia, they are, because of pregnancy, they go into hypercoagulable state. And since sir said this kidney don't have any control, so they are kind of like, last arteries, and they get vasculature gets blocked very fast, and they are more prone for cortical necrosis than the tubular necrosis. So these were the 2 points I wanted to add.
Thank you so much, Dr. Aparna. I think Dr. Gorakh wants to speak something. Sir.
Only one thing I want to add here, that we have to, in your list, absolutely it was fantastic. Only thing is that you try to avoid the usage of मैंने ऐसी नौबत ही ना आए कि हमें ब्लड कंपोनेंट्स यूज करने पड़े. एंड जैसे मैडम ने आपको बोला है कि इवन इफ वी हैव टू यूज, आइडियली दे शुड बी फ्रॉम अ सिंगल डोनर. वी हैव टू बी very careful that they should be from single donor, because multiple donor usage, again here we are fine, but after maybe in 3 or 4 months patient will die of the infection.
Thank you, sir. So I move on to case 2. Dr. Kavita, I am missing you, but I am moving to case 2. Otherwise, I will not be able to discuss. So case 2 is primary gravida, 28-year-old, delivered at 8 a.m. at PHC, referred to higher center at 12 noon for excessive bleeding PV. On examination, GC fares slightly confused, pale, pulse 140 per minute, BP 90 by 60 millimeter of mercury. On per abdominal examination, uterine fundus not palpable, PV vaginal packing was present. On investigations, the hemoglobin 8 gram%, TLC 29,800, platelets 1.2 lakhs, BT-CT prothrombin time normal, renal function test normal, and urine in the urobag was 100 ml. So the actions taken were shifted to OT for resuscitation after taking consent, blood products arranged, fluid started with whiteboard cannula, anesthetic called, packing removed, globular bulge felt in the vagina, bleeding present, reposition of the uterus done with difficulty as constriction ring was very tight, medical management given afterwards, uterine tone was not good, again balloon tamponade done, broad spectrum antibiotics given, and postoperative monitoring done. So this was the bulge which was seen per vaginally. So the question is to Dr. Mansi. What is shock index and what is the significance? What is the shock index in this particular patient?
Ma'am, actually, I have not gone through the text and theoretical things, but for blood pressure and basic vitals and ongoing blood loss, the quantity of ongoing blood loss, consciousness of the patient, and TPR, BP, whatever we routinely check in the post-delivery status are all important. And this patient, because I think had WBC count very high and already ongoing blood loss, is in bad picture, needs immediate diagnosis and intervention to stop blood loss and intervention.
Okay. So Dr. Revti, I would like to ask you, what is shock index? What is its significance? And what is the, how will you quantify shock in this patient? Dr. Revti, are you there?
Yeah, yes, ma'am. Again, here at the outset, I would like to add that thank you for the wildcard entry, and sorry I was not added in the group, and sorry if you felt that I didn't respond with the CV and the communication. I think there was a mistake. But here, actually, again, the theoretical part, I'm very afraid that I won't be able to justify this question.
Okay.
So
I will shock index, ma'am.
Yeah.
Shock index. Can I explain?
Yeah. Go ahead.
It is the heart rate divided by systolic blood pressure, and it has been studied in patients that who are either at risk of experiencing shock from a variety of causes like trauma, hemorrhage, MI, etc., or ruptured ectopic. And this shock index is known as is for hemodynamic stability. If a patient has an SI between 0.5 and 0.7, that is the accepted range. That is an indication that they have a pumping heart and which is adequate blood volume and good circulation.
Right.
Madam, can I add here? Madam,
Go ahead.
There is this modified shock index that we can easily
Yeah,
calculate
yeah.
at the bedside. Now, modified is similar line that heart rate divided by the mean arterial pressure. How do we calculate the mean arterial pressure? That is a diastolic pressure plus 1/3 of the systolic pressure, or diastolic pressure. So that figure that comes, that is a modified.
Mean arterial pressure is systolic plus diastolic divided by 2.
Divided by.
Yeah, it is not 1/3.
It is
It is diastolic pressure plus
1/3 of difference between
1/3 of
systolic
difference
and
between
diastolic.
systolic and diastolic
Yes.
pressure. Rather, it is 1/3 of the mean part pressure.
Pulse pressure.
See,
1/3
in
of
this case,
Pulse pressure, 1/3 of the pulse pressure.
Simple is, the heart rate and the systolic blood pressure.
Yes.
Every healthcare worker should be taught to calculate this, because in this particular patient, you have not seen the amount of blood loss. So it is the shock index which is going to tell you whether she is in shock or not. Dr. Gorak, I would like to have your expert opinion. Dr. Gorak,
Madam, I just want to add
opinion.
one thing. Excuse me.
Okay. You can go ahead. Please.
2 minutes, Dr. Nitika. I want answer from Dr. Gorak, please.
Yeah. I just wanted to say that Madam said this modified shock index. Actually, that has got an extension from 0.7 to 0.9 because
That is what I want to bring the. So
And if it is more
any
than
value
0.9,
more than 1 in modified shock index, she is very likely to land up with more mortality and morbidity. That is how we should be careful. And my bad, instead of you saying pulse pressure, I said this is diastolic pressure. So it is mean arterial pressure. Sorry.
And there's something of static shock.
Please let Dr. Gorak speak.
I feel we are going very theoretical. What practical shock index is used for is, madam, since you're talking about uterine inversion, in this case, it is a neurogenic shock. It is not a hypovolemic shock. So neurogenic
There are both
shock,
the things. There are both the things. That is what I want to signify. Wait.
Yes.
There are both the things. It is neurogenic, plus there is blood loss. And that is why I'm asking for shock index. That is why I'm asking Dr. Gorak to speak up for this.
Right.
Dr. Gorak.
Okay.
What I feel is, the very simple thing is just take the pulse and divide it by systolic blood pressure. We can do it in a second.
Yes.
In this, it was 140/90. So maybe it is 1.9 So it is 1.4.
Above 1. Simple.
Yeah, it is above 1. Simple.
Yes.
Why we are worried about this? The reason is only thinking, many a times the vital signs, we may feel that they are fine.
Yes.
So for example, if the blood pressure was 90 or something, many a times we may feel that, okay, systolic 90 no problem. Many a time we may feel that, कि अरे मैंने इसको बस्कोपेन दिया था या कुछ दिया था तो उसका पल्स ज्यादा है. That's why you have to understand the shock index.
Yes.
And especially in this case of mainly the neurogenic shock plus hypogenic shock, here the shock index usually it goes beyond 1.2. And then that suddenly give us an idea that I have to manage both the things. Probably that is a problem as well as the hypovolemic shock problem. And as what Madam she was saying, yes, uterine inversion diagnosis was a clinical one. That is absolutely right. But one must understand the shock index just to know मेरा case नहीं है. I have to immediately transfer her to the higher center, taking the primary care. For that only we have to use the shock index. That's what I feel. Over to you.
Dr. Swarupa, now I want to ask management and techniques of reposition. How will you reposit this? What antibiotic coverage are you going to use? Quickly,
Right. So
because we
reposition is, yeah, madam, I mean, quickly, and at least uterus has to go in, no? So, right. So if the patient comes to you immediately after inversion, that is the best time to reposit the uterus, because that time the uterus is relaxed. So the theory says that the part which comes last should go first. So ideally you can put it inside with the feast technique, your gloved hand catching the bulging part and fingers acting as a guide to trace the cervical rim, and then slowly supporting the fundus from the other hand in the abdominal wall. You start pushing the bulging part inside, and then it gradually recedes inside. This is one technique which is manual and should be done immediately. If there is already a constriction ring, either vaginal or cervical, then this patient can be given general anesthesia, uterine relaxants, and then we can do it manually again. There is a hydrostatic pressure theory, but frankly, I have not tried it any time. I have tried manual method and that has worked very well. But hydrostatic theory says that warm normal saline is pushed with the cannula in the posterior fornix, and the assistant closes labias around the cannula so that it makes a closed cavity. And with this hydrostatic pressure, gradually the bulging uterine parts are pushed inside. Frankly, I have not seen
Now quick answers I want. I want from Dr. Kavita, what antibiotic coverage and whether balloon tamponade was justified. Of course, I know Dr. Samartha is going to say you could have inserted the cannula, the suction cannula, but what antibiotic coverage and balloon tamponade? Quick answer, Dr. Kavita.
We would go for a higher antibiotic coverage because she was a referred patient and she had already been shifted. So a higher antibiotic coverage, like in my setup, I would like to give her piperacillin or a tazobactam for 3 days and metro and micacine. Because we need a wide coverage, and tamponade was justified because it was already late. We don't want the rigid ring was already formed there. So the balloon tamponade could just help her that the further PPH or further bleeding can be further bleeding can be controlled for that. So I think the balloon tamponade was justified for this patient.
Okay, Dr. Nitika, what long-term follow-up are you going to do for this patient?
Long-term follow-up, I could not get the question, madam. In what sense?
In next pregnancies, how long she should avoid pregnancy, what contraception? Only briefly, but what long-term follow-up is required for this patient?
Okay. First, I'll definitely promote her if she's completed with her family. Then definitely there should be a permanent contraception that should be advocated to them so that she'll not have any attempt of next pregnancy and she should not become pregnant. If she has not completed with her family, at least we'll space the pregnancy for 3 to 5 years. And this should be done with some kind of contraception which is not very temporary kind, like barrier or OC pills. At least promote her and ask her to come back for IUCTs so that that will take care of at least 5 years or 3 years for her. If she is becoming pregnant, then this status is to be put very highlighted with red pen and all marker on her paper that she has undergone inversion in her previous delivery. Now, the cause of inversion could be an iatrogenic on the part of doctor attempting in a wrong method doing the 3rd stage of labor, or it could be more adherent kind of placenta, which is not very morbid, but it was not easy to separate it properly. So she is a high risk case for placenta accreta kind of thing in her next pregnancy if she is having multi-gravity status. So evaluation of that thing should also be in her next antenatal period, whether we are dealing with a morbidly adherent placenta. So asking for a proper USG with Doppler. And
that's it, Dr. Nitika. I just wanted to ask regarding this patient. So this is shock index we've already discussed. And what care are you going to take? So proper labor management by trained staff, importance of training like Manyata training for the staff, AMTSL is important, inversion uterus should be corrected as soon as diagnosed, shock index should be taught to our staff, the healthcare workers, reference protocol should be followed, and shock and uterine deposition should be done simultaneously. I just wanted to ask, I've already shown the picture. How will you collect blood in this sort of a patient? Dr. Supriya, how will you collect? What amount of blood is collected in such sort of patients? Actually,
I
already
think,
the
madam, this
on
picture
the
is very beautiful and very self-explanatory. So I think if everybody just takes a screenshot, the answer is sorted. But on a little serious note, we would like to. I personally, I tell you what I do. At least 2 separate samples of EDTA and plain blood to be collected. In case the blood is not available or not sufficient in one blood bank, we should always have one extra sample to send to another blood bank. Just practical tips I am telling. When we collect the blood, in such a case, we should take 5 ml of blood in a plain, test tube and do a bedside checking for clotting time. It's a very simple, very safely can be done. We don't need to wait for pathologists to bring some elaborate instruments. By the bedside, we can see whether the clotting time is normal or no. For cross-matching, I would prefer 1.5 ml in or 2 ml in EDTA bulb and around at least 3 to 4 ml in a plain bulb to be sent for cross-matching purposes. So
thank you,
I
Dr.
guess.
Supriya.
Yeah.
Thank you.
Yeah.
Thank you. So documentation, the staff in attendance and time they arrived should be documented. The sequence of events should be documented. The administration of different pharmacological agents, their timing and sequence should be recorded. The time of surgical intervention should be written down. The condition of the mother throughout different steps should be documented, and the timing of fluid and the blood products should be given. Dr. Gorak, I would like to ask your final comments on this patient.
Right. Actually, almost all things are covered. Only one thing I should emphasize here, being a part of that NHM PPH committee member as well, that whenever we deliver any patient or whenever we do cesarean section, any obstetric patient when we are dealing, please put at least 18 number IV cannula.
Yes.
For all patients. Please do not use that blue 22 or please do not use that pink 20, but ideally the green 18 should be used. And whenever any PPH or something occurs at the initial stage only, we have to put 2 IV cannulas. Especially again, I will go for a gray, that is 16 number at one place and 18 number at one place. If we do this thing, we'll never lose a patient. That's it.
Thank you, sir. So we are going to discuss only 3 cases because they are long cases. Now the third case is to be taken by Dr. Aditi. Dr. Aditi, please go ahead.
Yes, ma'am. Thank you, ma'am, for the opportunity. Good evening, everybody. We'll start with the case number 3. Gravida 5, para 4, 30-year-old average build patient, referred from periphery for the case of non-progressive labor, and she was in labor since 10 hours. There was a history of taking tablet misoprostol 200 micrograms orally at PHC 4 hours back. On examination, general condition was fair, pulse was 110 per minute, BP 110 per 70, uterus term size, head was fixed, uterus hard, FHS regular. Per vaginally, cervix 6 centimeters dilated, fully effaced, vertex at -1 station, bag of membrane present, pelvis adequate. On investigations, blood group B positive, HB10, BTCT normal, platelet count 1.3 lakhs, and PT-INR could not be done. She delivered immediately after reaching the hospital. AMTSL done, placenta with membranes delivered and checked, no cervical, vaginal, perineal tear seen, uterine contraction, uterus well contracted. 2 hours after delivery, the patient was bleeding, fell from vagina, pulse started increasing 120 per minute, BP started falling 100 by 60. Uterus still contracted, call for help. Patient shifted to LR, steroids started. 2 whiteboard cannula inserted, anesthesiologist called, blood products arranged, injection to tranexamic acid, 1 gram IV diluted over 10 minutes given. Vaginal examination done, and the patient was managed.
Now
Should labor be augmented?
Dr.
Dr. Kavita,
Aparna.
will you take the...
Should labor be augmented is the question. Dr. Aparna? Dr. Nitika, if you are there. Dr.
Samartha
Nitika?
sir's this thing is on. He should be muted. Yeah.
Somebody can mute.
Host will have to do it.
Please mute Dr. Samartha, please.
Host can do.
Host can mute him, please.
Hello?
Yeah, can we go ahead?
Yes. He's still.
I'll just
it's
call
okay,
him.
I think. We can go ahead. I think.
Dr. Babita, can you help us? Can you mute Dr. Samartha?
Sahiti. Sahiti.
Okay. You want me to start off till then?
Yeah. Should the labor be augmented?
Frankly, we should be, true to the word obstetrics, which means wait and watch. And if there is no indication, if labor is progressing well and mother and baby are doing well, we should not unnecessarily augment labor. And here there should be a point of, what we were all taught as undergraduates and postgraduates to chart a partogram. And if the partogram wise she's progressing ideally, then I think the lesser we interfere, I have learned over the years, the better we fare the patient, better the patients fare. Leave things to nature if both mother and baby are doing well. We should, however, of course, be very vigilant. We should be on the lookout and ready if she requires any assistance. We should be there fully prepared. But if not required, then unnecessarily, I feel we should not augment labor.
Dr. Aditi, go ahead, please. Dr. Aditi.
Hello.
Dr. Aditi, are you there?
She is muted. Aditi, ma'am, unmute yourself.
Dr. Aditi.
Yeah.
Yes, ma'am. Ma'am, could we go to the previous slide?
Can we go back one slide?
Okay.
Yeah.
Then the second question is how long the patient should be monitored after delivery? Dr. Supriya, would you take the question?
First 2 hours, what we qualify, the third stage of labor, by definition, is by the time the afterbirths have delivered. The fourth stage of labor extends up to 2 hours of delivery. And it is a good practice to keep the patient in the labor room, not because the room is something special, but because we are always more vigilant. Our staff is more vigilant, even if we are not there, to look after the patient, and our staff should be instructed half an hour after delivery, the pulse, BP, per abdominal, whether uterus is well contracted, any active bleeding, whether there's any discharge, hematoma developing in the episiotomy. These are the things that half an hour after delivery should be seen. Again, at 1.5 to 2 hours, all our vitals should be recorded, and only then, once we are totally satisfied, we should shift her to the labor to the normal ward. However, we must also remember that the extended fourth stage is up to 24 hours of delivery, and that is the time when the baby and the mother both are most vulnerable, and we should all be vigilant for those 24 hours.
Yes, the next question.
Go ahead.
Ma'am, that was very nice.
Can somebody call Samartha sir? I don't have his number.
I tried calling him as he's not responding. I did try.
Samartha sir, can you hear us? Samartha sir? Samartha sir, can you hear us?
Can
you call the Sahiti?
I called him up, he's not picking.
Who is the host?
Steel Connect.
Steel Pharma. He's not there.
They are also gone.
Okay.
Hello?
Okay. Aditi, you go ahead.
Mute yourself.
Aditi, you muted yourself, yeah.
Aditi, go ahead.
Yeah, he's muting himself. He's done. Thank you.
Yeah.
Go ahead.
So, should blood products be arranged for all laboring patients?
If you don't mind me taking it, I personally do it. If blood bank facility is available in your town, I do blood cross matching for everybody. Just like in my town, it costs around 250 rupees, and it gives you a lot of less sleepless nights. And on, I will just relate one quick incident here. One patient registered with me. She was, diagnosed as AB positive. Unfortunately for the poor girl, she got a very bad vaginal test. She had a very, very, a non-elastic vagina. And when we sent the blood after bleeding started for cross-match, she turned out to be AB negative. And there was no AB negative blood in the blood bank. Luckily for me and for her 3 relatives were AB negative. So they had to be bled on the spot and blood had to be made ready. Since that, I have learned my lesson, whether primary, whether multi, all patients' blood I always reserve. Reservation takes no efforts.
Dr. Gorak, you want to say something?
Yeah.
Gorak, sir, you wanted to say something.
Yes, this is a very important step because even in one Supreme Court judgment regarding the postpartum hemorrhage during the cesarean section, it was mentioned that if prior blood reservation was not done, proper care regarding the blood and blood products was not done, and that's why the doctor was sued. So from that, it is very ideal that medico-legally for each and every delivery or cesarean section, and again in high-risk patients, we must do the reservation. Somebody will ask कि अरे फिर वो जो पहाड़ों में रहते हैं उनका क्या? Forget about them. You have an access to the blood bank. You do it for yourself. Forget about पहाड़ वालों के लिए हम हैं. It's very
Thank you,
clear.
sir. Thank you,
Can
sir.
I add something? Can I add something?
Yeah.
Even if the concerned blood is not available, always ask for a universal donor group till the time you are rescued with the part of PPH. That is O negative, K negative blood can be given in certain situations where the availability of concerned group is not there.
Okay. Even that is the reason ki the counseling regarding PPH, counseling regarding hypertensive disorder should be right from the day one of the ANC. There we have to take आपका ब्लड ग्रुप नेगेटिव है तो एटलीस्ट आपके कितने रिश्तेदार नेगेटिव वाले हैं उनके आप एड्रेसेस और फोन नंबर लेके रखो. This one line will save our life at the time of delivery. And we have to tell her again when she admits कि वो सब लोगों को एटलीस्ट फोन करके तो रखो कि कुछ लगा तो आपकी मदद कर. Simple thing.
Thank you, sir. Thank you. Aditi, go ahead, please. Methods of control, to control this bleeding.
Dr. Nitika, will you take this question?
Methods of control. Yeah.
The bleeding. What would you prefer? Vaginal clamps or cannula or path?
Yeah, I'll go for pharmacological methods. Simultaneously, I will also start looking for traumatic component of PPH in this case. That is
that has been checked. That has been done already.
Okay.
The uterus was well contracted now, so there was no atonic.
Pharmacological and
not atonic. Cervical tear and all should be ruled out.
Yeah, that has been checked. It has been mentioned. It is checked. Go ahead.
Then we can put 2 clamps that could be even sponge holder forceps that could be applied at 3 o'clock and 9 o'clock positions on the cervix. And this clamp will take care of descending cervical arteries, and somehow they are really good enough to give a good control in cases of PPH. Then ballooning could be one option because this patient was in a prolonged labor, and there was after that she has developed this PPH. I could not get whether the uterus was toned or it was atoned. I am not remembering that slide.
It was well contracted.
Okay.
There was no atonic PPH.
Okay. If that is not the reason, then the component of DIC should also be looked out because trauma is not
before
there.
Before that, it is very important that either we use these transvaginal uterine artery clamps, which is given by our own Dr. Paili sir, or you can use the PPH suction cannula, or you can do the balloon thing, right? So either of it, but before looking into that, you have to control the bleeding. That is very important. Dr. Aparna, role of carbetocin in this patient.
Ma'am, I've not used carbetocin much, but today as I was reading, I read a review from PubMed which had done 3 RCT control trials and many trials, and they had found that carbetocin and oxytocin are equally effective.
But here, not for the management, they should be used for AMTSL. That is what we want to convey.
Yeah.
So, Dr. Kavita, role of bimanual compression and aortic compression. Fast.
Yes, it has to be done. It does help in such cases because when you do a bimanual compression, you're directly pressing upon the aortic artery, and that does help to reduce the blood loss. So I think both bimanual compression and aortic compressions are both required in such patients. And even ma'am, for the blood loss, how do you quantify the blood loss? The question, you can quantify it according to less than 750 ml, around 750 for class 1 is less than 750, class 1 750 to 1000, then 1000 to 1500 ml is class 3, and more than 2000 you can say it class 4. So depending on the blood loss, there
We
are
don't want
various.
more than 2000. Remember, we don't want more than 2000. She goes into irreversible grade 4 shock.
Yes. So just the question which we lost there, so we just quantify them according to the ml. So both are required, and the protocol should be usually the blood transfusion protocol first.
You've muted yourself, Kavita.
Hello. Yeah, first we do the crystalloids to them so that the ratio, the volume is maintained in the ratio of 3:1, and then we can also add. By the time the blood is arranged, we can give crystalloids, and then you can give colloids also at times. So you can do that way for the blood transfusion protocol, and then give the blood cells or blood, whole blood.
Supriya, you want to add something, Dr. Supriya?
Madam, if you are pointing towards a massive blood transfusion protocol, then the rule of 6. So, start with 6 pack cells, 6 FFPs, and probably 6 platelets, reassess the situation and see whether she needs any more blood. Just here one point which, one of our bosses used to say, I don't know whether it really holds true. Carbetocin and oxytocin both have the similar effect. Now, oxytocin effect is it contracts the upper segment and relaxes the lower segment. In this patient specifically, we don't know whether it is the cervix which is gone lax and is bleeding, and in this case I would prefer to give her methergine over oxytocin. Yes. Because methergine will cause contraction of the cervix also. Yes. So just my point. Yeah,
you are very right, nice. Because here the uterus is well contracted, so that means she is bleeding from the lower uterine segment.
Yes. Dr. And Gaurav, madam, packing also works wonders in such cases.
That's yes. What we wanted to come to.
Yes, packing. Yes. I have multiple times. In fact, nowadays, I don't even wait for the PPH to proceed beyond a certain limit. With experience, this patient looks like she's trickling and she's bound to land up, and the cervix is like, like open, like a big cave. And just packing the cervix is sometimes sufficient, Yes. The bleeding is taken care of. Yeah.
So, Dr. Gorak, I want to ask you the next question. How will you manage the upper uterine segment bleeding and the lower uterine segment bleeding? The cervical bleeding, basically.
Okay. Now, first here I would like to answer that one should not underestimate the power of methergine. Because many a time it has happened that we are talking so much about carbetocin, we are talking so much about oxytocin, but forget about those 10.3 or 10% of the PPH cases. But in the rest, 80 to 90% of the cases, minus cardiac cases, minus some of the anaphylactic cases, otherwise almost in 80% of the cases, methergine still has a role. Upper part of the uterus will get contracted very well with methergine. That is the answer. Second thing, again, for even if within 15 minutes of the initial methergine, if it is not happening, then yes, we have to add either oxytocin or even the prostaglandins I may add. But definitely these things should be used, and directly one should not go to use the carbetocin in the management of PPH. One always should understand what is active management of the third stage of labor and what is the treatment of PPH, and then accordingly manage.
Thank you, sir. Dr. Aditi, take the points to ponder. Unmute yourself, please.
Yeah. As already discussed, unnecessary augmentation of labor is not required, and we all learn it from experience. Blood products should be cross-matched for every patient because we never know when we'll end up from 10 to 2. Active management of third stage of labor is mandatory. Fourth stage of labor, where observation is there, is a must. Any blood loss that causes hemodynamic instability should be detected earliest and treated urgently. Facility should be prepared. Novel, newer methods are useful. Prompt complementary action is needed. And anticipation, early detection, and appropriate management is very, very important.
So these are some few pictures which we should have in our labor room. And the FIGO also says that uterine massage should not be done, but oxytocin has to be used. It has, and in case if oxytocin is not there, then misoprostol can also be used. So
I have just one question for Gorak sir, ma'am. Can I ask?
Go ahead.
Because it is related but unrelated also. I had a patient, twin, IVF conceived, and when carbetocin started coming in vogue and we were all like, use carbetocin, we gave it because it says only prophylactic use of carbetocin is there. So we gave carbetocin, but she had refractory PPH, and ultimately we did a hysterectomy. But after carbetocin, oxytocin did not work, nothing else worked. So how is carbetocin so effective? Should it be given, or we should keep ourselves to using oxytocin only?
What I feel is, again, I am not against the carbetocin, but when since decades we are using oxytocin, we are using methargine and the prostaglandins with equal good effect and effectively and without causing our patients. The carbetocin has only added advantage as what they say is the raised shelf life. But otherwise, if you see practically, in all this post-COVID era, everywhere there is a refrigerator. Even in almost remote PSCs, remote centers, everywhere it is there. So I think one should not directly, because of the pharma presentations and all, one should directly jump on the carbetocin. But routine usage of the oxytocin, ergometrin, even the combination should be used even effectively. Vaginal, rectal, misoprostol in a proper dosage should be used. That is what individualize your experiences.
Gorak Babu, even prostadine works wonderfully. In refractory cases where you are given carbetocin, oxytocin will not act for next 40 minutes, but you can try 250 microgram of prostaglandin.
We are very much worried of that patient potty karti and all. Forget
These
about
are all
this.
random. Yes, yes.
Okay,
even I believe. Only contraindication is asthma. If she is not asthmatic, just go ahead and give her a prostadine injection. It really works wonderfully. So many times in cesarean, we give intramyometrial on the table. It works even faster.
We have to individualize our experiences and what we are comfortable. That should be used for our patients as per the guidelines. Because in guidelines, they have written oblique, but while saying, they will say carbetocin. But while writing, right, everything, oblique, even what madam showed, the FIGO guideline, everything is being given there. Right?
What
so,
was
yes.
the cause of PPH in this patient? It is still
lower segment bleeding. It was a
lower segment bleeding.
labor and lower uterine segment bleeding.
Okay, so here I just wanted to ask Dr. Gorak, like the 600 milligram misoprostol, which we can put it either in the uterus while cesarean and vaginally. How effective it will be, and it will be very cheap for the patients and doctors.
In fact, in my practice, after every cesarean section, we have put that 600 microgram of the misoprostol.
Exactly.
I have slept for years together, and that's why I'm like this.
Gorak Babu, if I may add, our anesthetist once recommended, and I am doing that, 600 misoprostol we put in the rectum just before giving spinal. We don't even have to wait for baby to deliver. Just before spinal, put it in the, once you finish scrubbing and draping, before, just spinal tablet
if the anesthetist
sorry, my bad. No, not just before spinal, just before incision. Spinal, after giving spinal, you paint and drape, that time we put.
What
I
you
had
are
put only once, and the patient went into high spinal.
correct.
600 microgram in a rectum. The patient went into high spinal, and I did not know.
No,
what
to give
do.
it, you put it after the spinal is given. My bad when I said before incision. Just after spinal, yeah.
I would like to.
देने का patient को. Yes, Gorak.
Yes, I would like to intervene here. Ki whatever we are doing, it should be as per the guidelines and recommendations. Because recommendations say that in the management of the PPH or whatever. So we have to follow the guidelines. That's why from the panel, message I would like to give is post delivery, definitely we can put the 600 microgram of the rectal. That's it.
I think that's a great
you,
point.
sir.
I think that's a great point. Yeah.
Thank you, sir. So we all know how to manage PPH, medical, mechanical and surgical management. We should know how to quantify shock. This is the PPH response bundle that if first response fails, then we can go to the second response, the refractory PPH bundle. And we are not taking the fourth case. But I want one point of advice from all the panelists regarding PPH, starting from Dr. Gorak.
Okay. For each and every delivery, for each and every obstetric patient, please use green 18 number cannula. That is number one advice. And second thing, please keep all the methargine, prostadine, oxytocin, everything ready in your labor rooms.
Dr. Aparna. Dr. Aparna,
18G cannula, oxygen, blood product reservation, and sir, as said just now, the PPH kit in a box. You should have kits in plastic boxes, PPH kit, PIH kit, everything in, so that you can ask for the kit and the staff brings it.
That's why Manyata accreditation. Dr. Supriya, your advice.
Anticipation, madam, most important. You be prepared and keep your staff in the loop. Maybe have a PPH drill with them, what to do and what not to do, because after all preparations, when patient lands in PPH, everybody just running helter-skelter.
Right.
So, a PPH drill should be in
protocol
place.
should be there. So a protocol should be there.
Yeah.
It can be an individualized protocol. Dr. Kavita, your advice.
She has left, madam. She has left.
Okay, Dr. Nitika.
Calculation of blood loss should be must by estimating method, by assessing the clinical shock, and by lab investigation supporting all the three. And besides that, you should also have this idea of prophylaxis of PPH, that you should work on reducing the risk of factors, that is identification of high risk factors during antenatal care, with proper counseling and giving them the area for delivery so that they will have a safe birth at that particular place.
Dr. Mansi.
Yes, ma'am.
Your advice, 1 point advice. 1 point practical advice.
I have a labor patient going on.
Okay, so that is most important. That means you should be alert during a labor patient. Dr. Revti. Dr. Revti. Dr. Swarupa.
Yeah, I feel, madam, PPH, that patient has got PPH should be accepted fast. Most of the times we are in mode of denial. We don't want to accept that it is a PPH.
Yes.
And the moment you accept it, treat aggressively. Most of the times we go wrong when we do too less and too late. So both these things should be avoided.
Yes. Great. Thank you so much. Thank you, Dr. Gorak. Thank you so much to all my panelists, Dr. Aparna, Dr. Supriya, Dr. Kavita, Dr. Nitika, Dr. Mansi, Dr. Reti, Dr. Sarupa, and my own co-moderator, Dr. Aditi. Thank you, Dr. Babita and Dr. Sadhna, for giving me this opportunity. Thank you.
Thank you so much for
Dolly, ma'am.
Excellent moderator and panelist.
Really, thank you, Dolly, madam. Really
and
fantastic
it was
job.
Very interesting cases. They made us really think about the condition.
And they didn't send the slides, so we were all in the dark.
Yes, we were on our toes, like what questions are coming.
Dr. Gorak, you remember moderating a panel in the high risk, the critical care conference in Ahmedabad. I was one of the panelists and you were the moderator. And the whole hall was full of all this,
But it was
right. Yes. Thank you so much, sir. Thank you.
I need to add one last line. Please keep ice factory on the head and factory on the head and sugar factory on the tongue, and we get
Superb.
Too good,
Message
too
of the
good.
day.
Ma'am, can I have the slide of that pads you had shown for showing to staff? Can you send it on the group? That slides
I'll
with
try and
pads.
do that. I'll try and do that. I'll try and do that.
Please, so that I can show to my staff and they have an
Here I would comment, get your center accredited by Manata. You'll have all these charts.
Yeah.
And the staff will also train. Okay. Chalo. Thank you so much. Over to you,
Thank
Dr.
you.
Gupta. Thank you, sir.
Thank you to Sadhna ma'am and Ayushi particularly. I don't know whether she's signed up here because she has done a lot of background work. So thank you to Ayushi Gupta also.
we should thank Dr. Ayushi because everywhere when she was connecting to us and everything she was
Yes,
doing.
yes. All background jobs she did.
To thank.
Dr.
Thank
Babita,
you.
are you there?
Yes, I'm there. So we had a wonderful panel today. Our expert panelist was too good. I loved that idea of ice factory on the head. Yesterday, I faced 2 patients of PPH after a long time. And by evening, I was totally drained out. I had to go to a meeting and a birthday party. I just refused. I said, I have to sleep peacefully taking a clonazepam. I can't handle it anymore. So we need an ice factory. I simply admire this idea. Moderators. So Sadhna ma'am has joined another webinar, I think. So I'll be thanking on her webinar on her behalf. Sahiti, kindly put ma'am's flyer. So we all know madam is really hardworking and the most deserving candidate for Foxy presidential candidate. It is a humble request to all of you to kindly vote for madam. Also ask all your friends, colleagues, everyone to vote for madam. We all need someone really deserving and hardworking like her in the highest post of Foxy. Now, coming to our official vote of thanks, I would like to thank our chief guest, Dr. Milind Shah and Dr. Parag Binewale for taking out time from their precious schedule and sharing their inputs in this webinar. I would like to thank our speaker, Dr. Sadhna Gupta, Dr. Samarth Ram, Dr. Sashi Maheshwari ma'am. Both the videos are wonderful and ma'am's talk as usual covered every aspect of PPH. Thanks to all our esteemed chairpersons, Dr. Rajendra Singh Pardesi, Dr. Jayashree More, Dr. Vinod Shethe, Dr. Aparna Paul Raul, Dr. Shraddha Paritkar, Dr. Sneha Bhuyar, and Dr. Shyam Sundar Sirsan. They conducted all the 3 sessions so smoothly, and also thanks for their wise inputs. Both our moderators, I should not forget to thank them. They're such a wise selection of cases. And of course, our panelists, our expert panel, Dr. Gorak, yes, he was actively involved throughout the panel and he gave some really good inputs, yes, which will really help us in our day-to-day practice. And all our panelists, they were so worried that we didn't get the slides. We just got the outline of cases, but then you all did so well. You see, when you do not know the slides, you tend to give more inputs because you study so hard. Like we don't know, so we have to study everything. And more inputs come only when you do not know the actual cases. So thanks to Dr. Aparna, Dr. Supriya, Dr. Kavita, Dr. Nitika, Dr. Mansi, Dr. Revati, and Dr. Swarupa. All of you did really well today. We have Sadhna ma'am also with us.
Yes.
So ma'am will join in. Yes, she will directly give her.
Yes, I'm audible, Babita.
Yes.
Am I
Sadhna
audible
ma'am,
now?
please
So,
do one
yes.
favor for us and thank Ayushi on behalf of all of us. She did a lot of hard work.
Yes.
Yes.
And thanks to you for the opportunity. Thank you so much, ma'am.
Thank you. Thanks once again. It was really wonderful session and we actually learned so many things about wonderful case discussion and all the presentations by the Dr. Shashi and always so many things. And the Samartha cannula, which we really want to say that very simple, very effective, but he has to emphasize this because this is the issue actually that we Indian as for our innovator, like the transvaginal uterine clamp suction cannula, Chhattisgarh balloon, is something we have to be proud of, and we have to be very confident in using. They are all very low cost measure when we are talking about so many things which is not available. And like Dr. Vinod, so many people shared that they are concerned about what practice they have. And this is also very important, that under the very glamour and glitz of a very high technology, which might not be available for our patient or our doctor, we instill confidence that every OB-GYN can make a very good practice. They can manage PPH of moderate severity. And when we have a good referral chain, actually we sound referral practices, we can save majority of women. So something about like we have to work together with a very all like our guest of honor faculty, and Gorakh has been something we have been all. I always say that, like, we have grown since 20 years, but I will say he's a ever young Turk of our federation. We can like he will take the flag of the change and for the change, and a very vocal person. So thank you, Gorakh. We always like that. And great discussion, Dolly and Aditi, like keeping the session on the this cases for the renal transplant, which is very much reality, and people actually don't know what to do. So a wonderful session, and thank you once again, Aurangabad, Akola, Kuls, Baramati, Islampur. A special thank Dr. Rajan Singh Pardesi, who, as I see always him as a elder brother figure since my all journey, and I'm really learned so many things, how quietly a person can do a change, like his so many things and organize wonderful things. Again, I might thank Dr. Aparna, Dr. Shatka, Dr. Shyam Sundar, Dr. Prerna, Dr. Priya, Revati, Dr. Rajesh, Dr. Ajit, Dr. Seema, and Dr. Vishal for coming together, all the help what we had, and all we photograph what we have. But finally we did it, and we did a wonderful session, and we always learn from each other. So thank you once again. And with this, I seek everybody's support, wishes for my forthcoming presidential election. So thank you once again.
Thank you, ma'am.
Thank you, ma'am.
Of course, we should also thank our IT team. Because of them, we had such good network, and our session went so very smoothly. So thank you, Tulika and Saiti. They also prepared such beautiful flyers. So yes, IT teams also.
Madam,
So
thank you for having
we all
us
remember
from,
Sadhna ma'am as, now I will not say deserving, I'll say only foxy presidential candidate. Yes, we want to see her in the highest polls.
Thank you.
Thank you, madam, for having us from Thane, me and Supriya. And wishing you a lot of luck and all our best wishes for your presidential elections. Thank you.